Good evening, everyone. Welcome to this virtual pathology workshop, which is a parallel session of the conference Management of Breast Cancer in New Millennium, recent clinical update from SABCS. I invite all speakers, chairpersons, moderator, participants, and panelists to log in for this virtual workshop. And at onset, I invite Dr. Anurag Mehta, Director, Lab Services and Research at Rajiv Gandhi Cancer Institute, to give welcome note and set up the context of this workshop. Over to you, sir.
Good evening, all. And on behalf of the organizing committee, I welcome you to this mini symposium on updates from San Antonio Breast Cancer Conference held in December 21. And you all know that San Antonio Breast Cancer Conference is a significant event in the annual calendar, especially for the breast cancer enthusiast. And it is here that many noteworthy discoveries are first time unveiled on molecular mechanisms, on new biomarker explorations, on trial data, on registration trials and therapeutic refinements. And one way to upgrade yourself in a very quick fix manner is to attend a SABC. Unfortunately, all of us cannot attend SABC. So this is a replicate of SABC, where the important topics are being discussed today. And Gurudat has spent hours choosing the topics and the appropriate speakers. And I congratulate Gurudat for doing that great job. Yeah, so you're welcome. So, you know, this is something that if you attend the SABC, you become aware of the contemporary happenings and the changing ground truths in the management of breast cancer. And I hope all the participants will get benefited. They will enrich their knowledge base and they will refine their practice standards. And I thank Dr. Meenu Walia and Vikas Talreja for giving us this opportunity to host this meeting, select the topics, select the speakers, and invite you. And I thank all the participants, and I also thank all the speakers, especially our young speakers who have very readily agreed to be part of this. I know that to prepare for these talks and especially to make them so laconic and brief to be completed in 7 minutes is a difficult task. But I guess these are the times of instant solutions and instant delivery of knowledge. So you will have to probably, stick to your timings because 8:20 is a dinner time for many. So try and finish. So try and finish by 8:30, if not 8:20. So thank you once again, everybody, for being here with us today. And let's hope that we all get benefited by this meeting and enrich ourselves to the contemporary standards of management in breast cancer. Thank you. And I hand it over back to Gurudat to get going with the science. Thank you, Gurudat.
Thank you, sir, for insight and inspiring words. I now invite Dr. Rajiv Tangri, who is National Head Histopathology and Cytopathology at Lal Pathology Labs in Delhi, to chair the session, the first session of this workshop. And I would request the speakers to stick to the time given for presentation. Over to you, Dr. Tangri, for the further session.
Thank you, Dr. Thank you, sir, and thank you for inviting me for this session, to chair this session. So we'll start right away. So as we all know, breast cancer is a quite heterogeneous disease, both morphologically as well as on the molecular level. And with a lot of new information being available about the human genome over the past few decades, new treatment options have now emerged, and disease is being now classified at the molecular level. The information has not only helped in deciding the prognostic implications for the patients, but also in identifying the subsets who will benefit from specific therapies. Apart from this, artificial intelligence, which is now rightly called as the third revolution in pathology after IHC and proteomics, is going to significantly change the way pathology is being practiced in future. So the session today will throw insights into these newer and emerging topics. We'll start with the sessions. I would request the speakers to stick to the timing. I will give a reminder at 6 minutes. And due to paucity of time, we will take the questions at the end of the entire session after all the speakers have completed their part. And I would request the audience to type their questions in the chat box, and we'll try to address as many questions as possible. So moving on to the sessions, the first speaker today is Dr. Shilpa Prabhudesai. She's a senior pathologist at Center for Oncopathology at Mumbai, and she will today talk about the new mechanistic insights to ER biology and endocrine therapies. So over to Dr. Shilpa.
Thank you, Dr. Rajiv. So new mechanistic insights into estrogen receptor biology and endocrine therapies was a subject which was discussed at the recent San Antonio breast meeting. Of the papers received, 4 papers were selected for a spotlight discussion. And I'm going to try and tell you very briefly about each of these papers. So estrogen receptor positivity is seen in about 70% of breast cancers. And as adjuvant therapy, it is managed either by reducing the amount of estrogen in the body or selectively modulating or degrading the estrogen receptor. If there are other pathways involved, like the MAP kinase or the PIK3CA or the mTOR pathways, then inhibitors to those pathways may be used. But everything is not rosy, because there are patients who develop resistance. Now, this resistance may be intrinsic or de novo, or it may be acquired at a later point of time. What causes resistance to endocrine therapy in these patients? There are different pathways, and they're not always mutually exclusive. It may be a crosstalk with other signaling pathways driven by the growth factor receptors. It may be an increase in the co-activators or a decrease in the repression. There may be genomic modifications of the receptor itself. One way is increasing the dose of the existing medication, but more often than not, a novel drug is required. So the novel drug may be from the same class of, the SERMs or the SERDs, or it may be a different molecule altogether, depending on the analysis of the breast tumor. The first paper talks about estradiol therapy that can improve response in estrogen receptor positive and resistant tumors. And how does DNA damage? You can see the damaged cells here by forming what are called as R loops, which are hybrid DNA RNAs. Now, this DNA damage can be easily repaired by PARP activity. And that is why the researchers thought that they will introduce a PARP inhibitor as well. This study was done using cell lines as well as xenograft models. And then you can see that there is a lovely synergistic effect of olaparib and estradiol compared to if these drugs are used alone. Olaparib or a PARP inhibitor is typically used in a BRCA positive cancer setting, but in this paper, they use it in a BRCA agnostic setting. They also tried looking at ATM inhibitors, but then they chose to take the study forward with PARP inhibitors because these are already approved for a subset of breast cancer. The next paper was to do with a drug called enzalutamide. Enzalutamide is a androgen receptor. It modifies the androgen receptor binding. And what I want to draw your attention to these graphs, the one on the left and the one on the right, and similarly these two. They look more or less the same. But the difference here is that this is the parent cell line of breast cancer. And this is the same cell line where they have knocked out androgen receptor. So if enzalutamide was, indeed targeting the androgen receptor, then it should have shown a difference in the relative cell number once the androgen receptor was knocked out. It doesn't. On the other hand, when the estrogen receptor is knocked out, you can see that there is a difference in what happens to the response to enzalutamide. So this made them postulate that the inhibitory effect is not dependent on androgen receptor, and it is the estrogen receptor which helps in enzalutamide action. At the same time, they also found that if there was a mutation in the estrogen receptor, enzalutamide did not act. The third paper concerned estrogen-related mechanisms in estrogen-positive breast cancers, where they analyzed single cells. They used RNA sequencing, and you can see that what again they did is they used two PDXs. One was a SC31 and one was called a GS3. Now, one of them showed suppression of growth when treated with estradiol, whereas the other group, it can be seen here as well. The tumor volume goes down, and in the SC31, it starts increasing. Also, the cells which are in G2MS phase increase over here. Now, in an attempt to try and explain why this happens, they postulated that perhaps interleukin-24 had a role to play, something like a tumor suppressor. So in one of the cell lines, the interleukin-24 expressing cells were more, and that caused a cell cycle arrest. Of course, they said that they need to investigate it further. And one of the points brought forward during the San Antonio meeting itself was that they had not taken into account that a xenograft would have the stromal cells not derived from the patient, and that they need to account for it as well. The next paper was about ApoBec. ApoBecs are from the family of cytidine deaminases, and they have a catalytic enzymatic function in causing DNA breaks. They were initially investigated extensively in viral infections, especially HIV, and then the interest in their carcinogenic function came. A typical signature 2 is considered significant for ApoBec mutagenesis. The group at MSKCC investigated this. How did they do it? It was a computational analysis. So they took data based on breast cancer patients, primary tumors, metastatic tumors, matched tumors, and they downsampled using whole exome sequencing, and MSKCC has their own impact profiling test. So they took all this data and they called forward for tumors which had the ApoBec signature to analyze them. What did they find?
1 minute remaining.
More than 30% of these tumors had ApoBec mutagenesis. They were usually associated with resistance to endocrine therapy. They had shorter response to first-line AI, and they may be a driver of poor response, as you can see in this graph. Interestingly, what they saw is that when they looked at matched samples, primary with metastatic, they found ApoBec signatures. Whereas the ESR mutation was seen usually later in the disease, not seen in the primary, but in the metastatic site. So the 4 papers that I have told you about is one is combination of estrogen and PARP and how it improves response, whether IL-24 has a tumor suppressor response, and enzalutamide, instead of working with AR, seems to be targeting the estrogen receptor in these cancers. And that ApoBec mutagenesis is a feature that indicates that this breast cancer will have poor prognosis. But of course, this is true for the ESR wild type ones. They did not study the ESR mutated ones and look at the ApoBec mutagens. So this is really very brief and a bird's eye view of the 4 papers that I was supposed to discuss. And thank you so much for your time.
Thank you, Dr. Shilpa, for your brief but very crisp discussion. So moving on to the next paper, which is the next speaker is Dr. Anila Sharma. Dr. Anila is Senior Consultant Histopathology at Rajiv Gandhi Cancer Institute, Delhi. Dr. Anila today will talk about transcriptional programming, ESR1 mutations, and novel targets and treatments in breast cancer. So over to Dr. Anila.
Morning. Good evening. Today, I, Dr. Anila Sharma, I'm thankful to the SABS team to give me this opportunity to present three very good posters, which were initially presented by Dr. Rinat Zilson from Dana-Farber, and she's a medical oncologist and a clinician scientist. These are the three abstracts which will be covered. So starting with the first poster, the ER receptor is a key driver and a therapeutic target in ER-positive breast cancers. And ER transcription is tightly regulated at various levels, be it ligand level or crosstalk between the receptor tyrosine kinases. ESR1 alterations are activating missense mutations are the Y537S and D538G, which lead in, to constitutive ligand independent activity, and they confer resistance to estrogen deprivation and relative resistance to tamoxifen and fulvestrant, leading to a metastatic setting. The crosstalk between ER and the other nuclear receptors or transcription factors regulate ER transcription. This can be in the form of decrease in the ER activity by competitive DNA binding, squelching or transcriptionary machinery, or increase in ER activity by cooperative DNA binding, tethering, or chromatin opering by the pioneer transcription factor. So FOXA1 is a pioneer transcription factor that facilitates ER binding, and FOXA1, it opens the condensed chromatin by displacing the H1 histone, and it dictates increased ER binding. FOXA1 alterations can either be in the form of mutations or amplifications. This is the first poster which was presented by Dr. Liu from Dr. Schiff's team. And the topic was the targeting the FRA1-dependent transcriptional nexus in a high FOXA1-driven endocrine resistant and metastatic breast cancer. They first studied the FOSL1, which is encoded by FRA1 gene by chip sequencing and RNA sequencing, and is FOSL1 is the top rank component of the AP1 complex induced by FOXA1 engaged super enhancers. Further, seeing at the Western blots at the protein level, it shows that genes are upregulated in the tamoxifen resistant cells, and SOX9 and KLF4 are downregulated, whereas there is silencing of the FRA1. So integrating the systromic data, it identifies the downstream transcriptional targets of high FOXA1 AP1 signaling. And there was an overlap between the secretory proteins, secretome 25, and genes FOXA1, FRA1, and CJUD, which were downregulated. The secretome 25 was significantly upregulated in ER-positive metastatic versus ER-positive primary breast tumors. The silencing of the FRA1, it reduces pro-metastatic phenotypes by diminishing the clonogenicity, the soft agar colonies, and migration. So to conclude, FRA1 potentially forms a feed-forward transcriptional access to amplify the high FOXA1-induced enhancer programming that activates a pro-metastatic secretome, making it a potential therapeutic target. Now coming to the second poster, which was inclusive of the androgen receptor. So 90% of the ER-positive breast cancers have AR receptors, and AR activation in presence of estrogen leads to reprogramming and repression of the ER-regulative proliferative genes through squelching of the co-activators and leading to tumor suppression. And as was seen in the initial paper in 2021, that AR expression was shown to be associated with good outcomes in ER-positive breast cancers. However, the older papers, they showed that AR overexpression is associated with endocrine resistance, and AR inhibition reduced estradiol-mediated proliferation. Now, these contradictory role of AR may be due to the contextual ER functioning, and was the basis for the second poster, which is mutant ESR1 receptor antagonize the tumor suppressor function of the androgens. This was the aim of the study, and through this study, the authors, they did the transcriptomic in ER mutant and wild type cells, hormone deprived, estrogen stimulated or androgen stimulated setting, and as expected, the gene set enrichment showed that the mutant cells showed increased signaling in the hormone deprived setting. Secondly, there was significant redistribution of AR or ER-AR binding sites in the ESR mutant cells, as was seen in CRISPR. The genes associated with overlap between ER mutant, ER-AR co-binding peaks, they showed differential expression in the mutant cells, and 65 genes showed worse outcome in the primary ER-positive breast cancers. Several genes from the 65 gene signature have increased expression in metastasis versus primary breast cancers, and ER binding density of the mutant ER-AR share binding sites in the estrogen-stimulated conditions were highest in the patient tumor samples of metastasis. So this was the conclusion, and they finally concluded that ER mutations decrease AR signaling in the estrogen conditions, and loss of AR tumor suppressor function may help metastasis in ER mutant tumors through collaboration between AR and mutant ER. Now coming to the last poster, which is ESR1 mutant breast cancer show elevated basal cytokeratins and immune activation. There was a PCA plot based on PAM50 gene expression and wild type and mutant models in 95 breast cancer cell lines. And they showed that in the PCA plot that the mutant cells, they clustered with the basal cell lines. And further, there was increase in the basal genes compared to the luminal genes in the mutant cell models as well as in the metastatic breast cancer cells. The basal cytokeratins were the leading enriched basal markers as seen on the fold chain correlation of the basal genes and on qualitative PCR. And basal cytokeratins are expressed in the cells with low ER expression. The expression of the basal cytokeratin is not dependent on ER binding and is increased with ER downregulation, as seen by the genomic chip sequencing at chromosome 12, which harbors the basal cytokeratins, and there were no ER peaks seen in the wild type or the mutant cells. See, looking at the first picture, the basal cytokeratins are located within a genomic locus of chromosome 17 that has CTCF and cohesion binding in the first portion of the picture, this in the middle portion, and the super enhancer and PR binding as can be seen in the lower third of the picture. There is increased binding at the CTCF peaks in the mutant cells compared to the wild type cells, and the basal cytokeratin expression is dependent on PR. The basal cytokeratins, high ER positive breast cancers and ER mutant breast cancers are commonly enriched immune activation pathway as shown in the fold chain correlation of immune genes. And the S100, A8 and A9 were the top immune related genes enriched in the basal cytokeratin, high ER positive breast cancers and ER mutant breast cancers. So summarizing everything together, they propose this working model where presence of ER mutation decreased estrogen receptors and PR at the super enhancer site upregulates the basal cytokeratin CTCF chromatin loop, which leads to the expression of the cytokines. To conclude, the ESR mutant cells and tumor show enrichment of basal subtype markers, which is led by the basal cytokeratins, and gain of the basal cytokeratin associates with the activation in ESR mutant cells via S100, A8, A9, TLR4 paracrine signaling crosstalk between epithelial and stromal cells. Thank you.
For the elaborate talk and sharing the important papers with all. So as mentioned earlier, we'll take questions at the end of the session. So I would request the participants to type their questions in the chat box, and please also mention the name of the speaker to whom the question is addressed to. So we move on to the next talk, which is by Dr. Indu Arun. Dr. Indu is consultant Department of Pathology at Tata Medical Center, Kolkata. She will be talking about expanding downstaging criteria in AJCC pathologic prognostic staging using Oncotype DX recurrence score assay in T1, T2, and 0 hormone receptor positive patients controlled in TAILORx trial. So over to Dr. Indu.
Thank you, sir. Good evening, everyone. So the topic given to me is expanding downstaging criteria in AJCC pathologic prognostic staging using Oncotype DX recurrence score assay in T1, T2 node negative hormone receptor positive patients enrolled in TAILORx trial. So this study was presented as a poster in San Antonio Breast Cancer Symposium, and the study was conducted by Olga Cantor and her team from Brigham and Women's Hospital. So recent data has shown the importance of tumor biology in breast cancer outcome. And when these biologic factors are incorporated into staging systems, this will help to improve the prognostic modeling for outcomes compared to the traditional anatomic staging. So this led to the development of pathologic prognostic staging system by AJCC 8th edition, which incorporates both anatomic staging, anatomic factors such as the TNM category, as well as the biologic factors, that is the receptor status of the tumor, ER/PR HER2 status, grade of the tumor, and genomic assay. So AJCC 8th edition recommended the use of Oncotype DX breast recurrence score assay, which is based on the expression of 21 genes, and it is measured using an RT-PCR method and reported as a numerical score measuring from 0 to 100. The Oncotype DX assay helps to stratify the risk of distant recurrence and also predict the benefit of chemotherapy in hormone receptor positive HER2 negative breast cancer. So the prospective randomized trial that was performed to further validate the clinical usefulness of the Oncotype DX assay is the TAILORx trial, which used a cutoff of 11 to define low-risk patients. Low-risk patients had a recurrence score less than 11, and they have less chance of distant recurrence, as well as less chance of response to chemotherapeutic agents. So the AJCC 8th edition incorporated this initial data from the TAILORx trial, and they specified that all hormone receptor positive HER2 negative patients with T1, T2 node negative disease of any grade and recurrence score less than 11 will be classified as pathologic prognostic stage 1A. However, subsequent results from TAILORx trial found that those patients with recurrence score less than 26 may also be low risk, and these patients may not benefit from chemotherapy. Moreover, a retrospective SEER analysis recently conducted by the same team, that is Cantor et al., suggested that all node negative single node positive patients with recurrence score less than 18 have similar clinical outcomes as compared to PPS 1A patients of the AJCC system, and these patients can be downstage to PPS 1A. Similarly, RX Ponder trial randomizing patients with recurrence score less than 25 and 1 to 3 positive nodes to chemoendocrine therapy or endocrine therapy alone did not find any difference in disease-free survival in postmenopausal women in these two groups. These data shows that the recurrence score results may be useful to identify another group of low-risk patients beyond the already described low-risk patients, that is defined as T1, T2 N0 patients with recurrence score less than 11, and these patients can also be downstage to PPS 1A disease. So the present study included patients enrolled in the TAILORx trial, and since long-term prospective data is not now available from the TAILORx trial, the objective of the study was to examine if recurrence score criteria for downstaging PPS 1A can be expanded using patients enrolled in this trial. So the TAILORx trial assigned T1, T2 N0 hormone receptor positive HER2 negative breast cancer patients with recurrence score less than 11 to endocrine therapy alone, more than 25 to chemotherapy followed by endocrine therapy, and the mid-range 11 to 25 were randomized to endocrine therapy or chemoendocrine therapy. A total of 9,535 patients were available for analysis. So according to the PPS classification, stage 1A disease was defined as all T1 N0 disease with any grade or any recurrence score, T2 N0 disease with grades 1 to 3 and recurrence score less than 11, or grade 1 to 2 and recurrence score more than 11. So not stage 1A was defined as T2 N0 disease grade 3 with recurrence score more than or equal to 11, or T2 N0 PR negative grade 1 to 3 and recurrence score more than or equal to 11. Statistical analysis was performed using Kaplan-Meier method and comparing patients that did and did not fall into the AJCC PPS 1A category. These are the characteristics of the patients who were enrolled in TAILORx trial. Most of the patients were PT1. Most of them had ER/PR positive disease. Majority had grade 2 disease, and most of them fell into the recurrence score categories ranging from 11 to 25. And most of them had fell into the category of AJCC PPS 1A stage. When Kaplan-Meier recurrence-free survival of the treatment, it did not show any statistically significant difference between the PPS 1A category and non-PPS 1A with recurrence score less than 18. However, statistically significant difference was found between PPS 1A and non-PPS 1A recurrence score of 18 to 25 and not PPS 1A recurrence score more than 25 categories. Similar results were observed when recurrence-free survival curves were derived in patients receiving endocrine therapy, endocrine therapy. So to conclude, this is in this unplanned analysis, patients with T1, T2, N0 hormone receptor positive, HER2 negative breast cancer with recurrence score less than 18 had similar recurrence-free survival to patients belong to the PPS 1A category of the current AJCC system, regardless of treatment. And so consideration should be given to expanding the criteria to include recurrence score less than 18. So my take on the study, so AJCC 8th edition took 11 as a cutoff to define low-risk patients based on the initial data from the TAILOR-X trial. This study, the present study was done on the same group of patients enrolled in TAILOR-X trial, and now with long-term follow-up data, it suggests that patients with the recurrence score less than 18 could also be considered low risk, and this would bring in more patients into the low risk category and decreases their exposure to aggressive treatment, which may not be beneficial to them. So in our setting, the results of the study may be applicable to only few patients who undergo Oncotype DXSA. However, it may be useful in future when more and more patients go for Oncotype DXSA and other molecular assays. So these are my references.
Thank you, Dr. Indu, for timely completing the talk and sharing with us the guidelines on use of gene signature profiling test Oncotype DX, which is very popularly used these days. Thanks a lot. So we'll move on to the next talk, which is by Dr. Iona Lekha Matthew. Dr. Iona is a senior consultant pathology at VPS Lakeshore Hospital, Kochi. She will talk about PAM50 intrinsic subtype and risk of recurrence score for prediction of endocrine therapy sensitivity and pathologic response to chemotherapy in postmenopausal women with clinical stage 2 or 3 estrogen receptor positive HER2 negative breast cancer in the alternate trial. So over to you, Dr. Iona.
Good evening. Warm greetings from Cochin. At the onset, I would like to thank the organizers for giving me this opportunity to talk on this topic. This was a poster of distinction presentation at San Antonio Breast Cancer Symposium in December 2021 by Cynthia et al. And was a part of the Alliance trial in oncology. The topic was PAM50 intrinsic subtype and risk of recurrence score for prediction of endocrine therapy sensitivity and pathological response to chemotherapy in postmenopausal women with clinical stage 2 and 3 estrogen receptor positive and HER2 negative breast cancers in the alternate trial. Before I start the topic, a few words on PAM50. PAM50 is a 50 gene signature that classifies breast cancer into 5 molecular intrinsic subtypes: luminal A, B, HER2 enriched, basal-like, and normal-like. These 50 genes identified were refined from a list of 1,906 genes which were found in previous microarray studies. Molecular subtyping using the PAM50 gene signature can be performed using gene expression derived from microarrays, RNA, or qRT-PCR. A little bit about the background. Now, neoadjuvant endocrine therapy offers an opportunity to assess endocrine therapy sensitivity for ER-positive, HER2 negative breast cancers and potentially to tailor therapy. A Ki-67 index of more than 10% on biopsy after 2 to 4 weeks of neoadjuvant endocrine therapy identifies patients with intrinsic endocrine therapy resistance. A pathological complete response, or a PCR, and modified preoperative endocrine prognostic index of 0, that is M-PEPI score of 0 at PT1 and T2 N0 status and a Ki67 index of less than or equal to 2.7% at surgery indicates sensitivity to endocrine therapy. However, on-net biopsy is not always acceptable or feasible and delays the ET sensitivity determination. PAM50 ROR score, the risk of recurrence score, and intrinsic subtype by tumor RNA profiling are prognostic in patients with early stage ER positive and HER2 negative breast cancers and can predict PCR rates to neoadjuvant chemotherapy. They therefore hypothesize that PAM50 analysis on pre-net biopsies could predict the likelihood of a high on-net Ki67, M-PEPI score of 0 or PCR at surgery, and PCR for patients tried to neoadjuvant chemotherapy. The alternate trial is a phase 3 study which randomized postmenopausal women with clinical stage 2 or 3 ER-positive HER2 breast cancers to receive neoadjuvant anastrozole, fulvestrant, or both for 6 months before surgery. The research biopsy was required at pre-net and at week 4, then optional at week 12. Patients with Ki67 index of more than 10% biopsy on week 4 or 12 were discontinued on NET and offered neoadjuvant chemotherapy. PAM50 intrinsic subtype and ROR values were generated from mRNA sequencing analysis on pre-net biopsies using open source informatics and evaluated for prediction of on-net Ki67 of more than 10% at week 4 or 12, PCR or M-PEPI score of 0 post-net, and PCR post-neoadjuvant chemotherapy. Now coming to the results, 749 patients of the 1,297 eligible trial patients were included in the analysis. Of them, 548 were excluded due to insufficient pre-net tumor for RNA sequencing or PAM50 normal subtype. Now, similar to the entire alternate population, the rate of Ki67 was more than 10% at week 4 or 12. That was 24.4%. The rate of M-PEPI score 0 PCR post-net was 19.8%. This is the study population. The majority of luminal A or ROR low tumors were G1, G2, which is more than 90%, with a Ki67 index of less than or equal to 10% in 80% of the cases. Non-nuclear breast cancers were often grade 3, that is 61%, with the high levels of Ki67, that is 26%, with a Ki67 of more than 50%. However, non-luminal tumors were not luminal high grade, were not uniformly high grade, or with a high Ki67, since 39% were grade 1 or 2 and 28% had Ki67 index of less than 10%. Both the rates of Ki67 were more than 10% at week 4 or 12, and modified PEPI score of 0 or PCR differed significantly with respect to PAM50 subtype or the ROR category, such as luminal A or the ROR low breast cancers were least likely to have a Ki67 index of more than 10% at week 4 or 12 and were most likely to achieve M-PEPI score of 0 or a PCR. 93 of 168 patients tried to neoadjuvant chemotherapy had RNA sequence results yielding 26 luminal A, 49 luminal B, 4 basal and 14 HER2 new enriched with a PCR rates of 0, 6.1%, 0 and 21.4% respectively. There were 10 ROR low, 39 medium, and 44 high tumors with a PCR rate of 0, 5.1, and 9.1% respectively. This is the sensitivity of neoadjuvant endocrine therapy by PAM50 in the rate of Ki67 of more than 10% at week 4 or 12. This was statistically significant in the PAM50 subtype and the ROR category. The same was true for the rates of M-PEPI score of 0 or PCR at surgery post-net. The sensitivity of neoadjuvant chemotherapy by PAM50, both baseline ROR and intrinsic subtype are predictive of early on net Ki67 of more than 10% and M-PEPI score of 0 or PCR at surgery after net. For patients tried to neoadjuvant chemotherapy based on an early on net Ki67 of more than 10% and HER2 new enriched group had the highest PCR rate and no PCRs were observed in luminal A. To summarize, PAM50 non-luminal subtypes were observed in 7.2% of the alternate trial population despite high ER expression at the time of diagnosis. Non-luminal tumors were not uniformly high grade or with a high Ki67. a Ki-67 index of more than 10% at week 4 or 12 on neoadjuvant endocrine therapy, and an MPEPI score of 0 or PCR status at surgery post-NET differed significantly with respect to PAM50 subtypes or the ROR category. PAM50 non-numeral subtype with high ROR were more likely to have an early on net Ki-67 of more than 10% and non-zero MPEPI score, indicating resistance to neoadjuvant endocrine therapy. For patients triaged to neoadjuvant chemotherapy based on an early on net Ki-67 of more than 10%, the HER2E group of tumors had the highest PCR rate, and no PCRs were observed in luminal A tumors. Take-home message: PAM50 intrinsic subtype may be useful for directing neoadjuvant therapy in postmenopausal patients with ER-positive HER2 breast cancers. Ki-67 and a PEPI triage approaches are helpful in determining further management studies. Thank you.
Thank you, Dr. Ayana, for the talk on PAM50 and its use in deciding and prognostication of chemotherapy. So we move on to the next topic. The next speaker is Dr. Ruchika Goyal. Dr. Ruchika is Senior Consultant, Laboratory Medicine, Pathology and Blood Bank at Medanta Hospital, Gurugram. Dr. Ruchika will talk about breast cancer index and assessment of tumor proliferation by molecular grade index within distinct HOXB13 IL-17BR ratio subsets. So Dr. Ruchika, over to you.
Good evening, sir. I thank the organizers for having me here and present this topic. As we are all aware that greater than 50% of recurrence in ER-positive breast cancer patients occurs after 5 years of adjuvant endocrine therapy, and the incidence can be anywhere about 5%. Now, we've been hearing that there are various molecular markers in the market like Oncotype DX, PAM50, Prosigna, IHC4, etc. So these are helpful to predict recurrence, but they're not very helpful in predicting late recurrence. And especially, they do not predict patients which would benefit with endocrine therapy post 5 years of treatment. So the new kid on the block that developed was the breast cancer index, which is based on 2 independent molecular gene expression markers, the molecular grade index and HOXB13 IL-17BR ratio. So what are these? The molecular grade index depends on 5 cell cycle genes, and it basically recapitulates histological grade and tumor proliferation. And
I'm sorry for intervening, your slides are not moving.
You can't see the slides?
We can see the slide, but your slides are not moving.
Oh, slides are they moving now?
No, ma'am. Just reshare.
Change it to slideshow mode.
Okay. Can you? Are they changing now? Or maybe the organizers can.
No.
So I'll just end the show and the organizer.
Please reshare.
Please. Okay.
Okay. Try moving now.
Ma'am, I have shared your slide. You had just to say next slide. Then I.
Okay, fine. Okay, fine. So please, then the next slide. Yeah, the next one. Yeah, so the molecular grade index is based on 5 genes which are associated with histological grade and tumor proliferation, and these are good prognostic marker to predict risk of recurrence in ER-positive patients. Next, please. The HOXB13 IL-17BR. Now, these genes do depend on either tumor grade or proliferation. These depend on the estrogen receptor signaling pathway and as to how responsive a tumor is to estrogen. And these are a good marker for prognostic for early and late distant recurrence, and also to predict that which are the group of patients which would benefit with extended adjuvant endocrine therapy post 5 years of treatment. Next, please. So this was the abstract which was presented recently at the San Antonio Breast Conference by Reshma Mahatani et al. So just briefly into what was this study. Next. The aim of this study was the correlative analysis were performed to evaluate molecular markers for proliferation and ER signaling and their relationship to risk of late distance recurrence and clinical features in patients receiving breast cancer index in routine clinical care. Next. So a total of 18,853 patients were evaluated, and of this, the pathology was available for 7,477. Next. The molecular grade index by HI categories was subdivided based on few clinical and pathological categories, and some of these were the time of testing. Less than 1 year was considered as early recurrence and 4 to 7 years as late recurrence. Presence or absence of lymph nodes. Next. Age at diagnosis less than 50 years or more than 50 years. Tumor size, grade, and there were two distinct prognostic risk categories, low and high risk. Next. Coming on to the results, it was seen at the end of 1 year, the recurrence was seen in 53% patients who showed a high MGI, whereas at the end of 4 to 7 years, the MGI was seen in 61% patients, showing that this was statistically significant. When they compared this with node negative and node positive, it was seen that in the HI low subset, the MGI was 31% in both. The HI low subset, node negative or node positive. And thus there was no significance of MGI category within the HI low or high subsets. Coming on to the next, with age, again, the distribution of age group, that is less than 50 or more than 50, did not have any effect on either the MGI or the HI status, because both the MGI was 29%, both whether patients were less than 50 years or above 50 years. Coming on to the size of the tumor. Size of the tumor also, whether a tumor was T1 or the tumor was T3, the number of patients showing the HI low, MGI was 31% in both categories. And when in the HI high subset, the MGI was 24% in T1 and about 27% in T3, which was again not statistically significant. So basically node, age, size of the tumor did not have any effect on these two markers. Next, please. The grade of the tumor had a direct correlation with MGI proliferation, and it was seen that in grade 1, there were about 36% patients which just showed an MGI high. But when the grade increased to grade 3, it was 89% patients which showed MGI high, which showed a strong relationship. Coming on to the HI subset, there was a modest direct relationship because grade 1 tumors were predominantly responsive and their HI was low, about 70%. But as the grade increased, the HI low category of patients was reduced to only 36%. When MGI was compared in the HI low subset, as the grade increased, the proportion of patients decreased from 45% to 23 to 5%, while the MGI high remained relatively constant through all the 3 grades. Next, please. This was the MGI and HI distribution within the low and high distant risk categories in node negative early stage breast cancer. It was seen that in N0 tumors, those who had high risk for late distant recurrence, they showed a heterogeneous distribution of MGI and HI. For example, 56% patients showed MGI high and HI high, whereas there was 35% patients who showed a high proliferation and also had a responsiveness to endocrine therapy. Coming on to the low-risk tumors, they also showed a similar heterogeneity with 55% patients showed low proliferation and high endocrine responsiveness. But then we also had a category of about 26% whose proliferation was high and their responsiveness was also present. So thus stating that there is a proportion of patients who have high endocrine or high proliferative signaling, suggesting that one of these pathways is responsible for distant recurrence and it is not solely dependent on one pathway. Next slide, please. So to conclude, high tumor grade correlated strongly with MGI and modestly with HI status, indicating that only a subset of high-grade tumors were highly proliferated and were also endocrine responsive. Proliferation and endocrine signaling were both associated with late distant recurrence in hormone receptor positive breast cancer patient. And therefore, a combination approach of combining both these markers can be used as a better prognostic and predictive marker. And the further advantage of breast cancer index over other molecular markers is that it divides and stratifies patients only into two distinct categories of low and high risk, and thus eliminating the intermediate risk group. Also, it is more beneficial to predict distant late recurrence compared to the other molecular markers available. Next, please. So these were some of the references used. Thank you.
Thank you, Dr. Ruchika, for your presentation on the breast cancer index and its utilization in the prognostication and guiding treatment of breast cancer. We move on to the next topic. The next speaker today is Dr. Gaurav Sharma. Dr. Gaurav is Senior Consultant Pathology and Blood Bank at Dharamshila Narayana Super Speciality Hospital, New Delhi. And he will today talk about a multi-feature AI-based solution for breast cancer diagnosis in breast biopsies, a prospective blinded multi-site clinical study. So over to you, Dr. Gaurav.
Okay, good evening all. First, I want to congratulate the organizing team for conducting such an educative and informative session with wide range of topics of interest on breast oncology in such a difficult time. I would also like to thank them for giving me an opportunity to speak on one such very fast, upcoming and intriguing topic. So coming on to the topic for today's talk, that is a multi-feature AI-based solution for cancer diagnosis in breast biopsies. This was a study which was done by Annie Vincent et al. In December 2021. Yeah. So it was a result of a unique research partnership between Ibex Gallen Breast Solution and Institut Curie France, and also Maccabi Healthcare Services, which is Israel's second largest healthcare maintenance organization. Importance of this study lies in the fact that breast cancer remains the most important and common malignant disorder, with more than 2 million new cases and approximately 700,000 deaths globally in year 2020 alone. So it was conceptualized that automated or computer-assisted diagnostic solution can provide good support to the pathologist in terms of greater efficiency and possibly better accuracy in quick time. But to bring these solutions to the forefront of healthcare diagnostics, they first require to undergo rigorous, blinded, and independent multi-site clinical studies to establish them as a bona fide tool. So this current study is one such clinical study. Objective of this study was simple and straightforward. That is, validation of performance of this AI solution for detection of invasive and in situ breast carcinomas, grading of DCIS, detection of additional features like tumor infiltrating lymphocytes, and the performance was validated against rigorous ground truth established by multiple reading pathologists. As already talked, it was a multi-site blinded study. First raid was done by Institut Curie, and then second raid was done at Maccabi Healthcare Services, Israel. It was a prospective study which was done on retrospectively collected cases. 6 pathologists participated in this study, and multiple scanning system and staining platforms were used. So coming on to the summary of the result, which is as follows. Out of the 436 total number of cases, 156 cases were of invasive breast carcinomas, 280 cases were non-invasive lesions. And the sensitivity and specificity of diagnosing invasive carcinoma out of these 436 cases remained more than 95% sensitivity and 93% specificity. Out of the 248 non-invasive tumor lesions, 103 cases were diagnosed as DCIS, while the rest of the 145 cases were designated as benign and other lesions. The sensitivity and specificity both remained high, that is more than 93%. These invasive carcinomas included even the rarer subtypes like metaplastic, acinic cells, tubular, apocrine mucinous, and micropapillary features. And the performance of DCIS versus ADS detection was also very good, that is having specificity of more than 86% and sensitivity also more than 87%. In differentiating between IDC versus ILC, out of the total 153 cases, 98 cases were designated as IDC and 55 cases were designated as ILC by the AI system. The sensitivity remained high with more than 92% and specificity of more than 92% again. Now, out of the 134 cases which were non-invasive, 88 cases were either intermediate grade or high grade DCIS. The rest of the lesions were either low grade DCIS or ADH. And the sensitivity and specificity remained high, more than 84%. It is worth mentioning that few cases were missed by reader pathologists but picked up by AI. Like in first case here, we can see a lymphovascular invasion, but which is really hard to detect on HNE. It looks like sclerosing adenosis or something like macroadenosis. But AI system picked it up nicely and correctly identified it as an invasive lesion and labeled it as lymphovascular invasion. In second case, there was ILC in the background of granulomas. So it was correctly labeled as ILC with granulomatous mastitis by AI. Sorry. Third case was of tubular carcinoma along with fibrocystic change of the breast in the background. It was once again nicely picked by AI, although it was initially missed by a reader pathologist. In another such case, there is a focus of IDC in the background of dense, heavy lymphocytic infiltrate. It was missed by a pathologist, but then again, it was picked by our AI system. So to conclude, this study validates the accuracy and overall performance of AI-powered diagnostic solution for a variety of breast malignancies. This AI solution also is possibly the most accurate such solution so far in breast cancer detection. This AI accurately detected all the different types of tumors and even graded in situ lesions successfully. This AI solution can also alert on misdiagnosis by the reader pathologist. AI solution performed equally well in two different countries, that is France and Israel. This study thus advocates its more routine implementation in cancer diagnosis on breast biopsies. So, thank you.
Thank you, Dr. Gaurav, for the talk on a topic which is very close to my heart, and have personal experience of using this Ibex Gallon solution. We are currently using it for prostate. And I do agree with Dr. Gaurav that this has excellent results. So thank you, Dr. Gaurav. Now we move on to a panel discussion. The panel discussion will be led by Dr. Maushmi Suryavanshi. Dr. Maushmi is Senior Consultant Molecular Diagnostics at Rajiv Gandhi Cancer Institute and Research Center, Delhi. And she will moderate the panel discussion on the topic reclassifying VUS. New techniques can solve the puzzle once and for all. I would also invite the panelists. The panelists are Dr. B. Vishal Rao, Senior Consultant Pathologist at Basavatak Rakam, sorry for that, Indo-American Cancer Hospital and Research Institute, Hyderabad. Dr. Anu Iris, Consultant and in charge in Department of Clinical Biochemistry, MBR Cancer Center and Research Institute, Kerala. and Dr. Aparna Dhar, Head of Department, Medical Genetics and Genetic Counseling at Core Diagnostics, Delhi. So I would hand over to Dr. Maushami to take the panel discussion further.
Okay. Can you hear me? So can you see my screen?
Yes.
Okay. Yeah, good evening, everybody. First of all, I'd like to thank the organizers for giving me this opportunity. And I am super duper excited to be discussing this topic, which is my actually clinical colleagues tell me that this is the most malignant diagnosis which we give when we report BRCA. So this is reclassifying VUS. New techniques can solve the puzzle once and for all. And before I start the panel discussion, so I would like to show you this slide. So this slide is from the Nature 2021 journal, where the NIH has made bold predictions for human genomics by 2030. So that's very near, practically 8 years from now. And in this, the 7th prediction is that the clinical relevance of all encounter genomic variants will be readily predictable, rendering the diagnostic designation of variant of uncertain significance, that is VUS, obsolete. So with this background, I would like to start the panel discussion. So first of all, my question is to you, Dr. Vishal. So this is a 40-year-old female with breast cancer, which is ER/PR positive and HER2 negative. And the doctor, the clinician oncologist, advised BRCA testing, and NGS was done. And on sequencing, this BRCA variant was found. So I would like to ask you, how would you approach such a case? So what do you do when you find a variant?
Thank you, ma'am, for the question. Yeah, actually, we work in our hospital. We work on a iron tolerance system, and when we get a variant, and usually, you know, there is an inbuilt software where it compares different predictor tools, and they help us to assess whether which category it falls, whether it is pathogenic, whether it is benign-like, or in its VUS. So according to that, and in another software also, we compare with other tools also, and after comparing them, we come to conclusion that yes, this is a pathogenic, or it's a benign-like, or a VUS.
Okay, Dr. Aparna, will you like to add something to that?
Sure. So good evening, everyone. Sorry. So we also use the iron tolerance, and we use the Thermo Fisher S5, which yes does have its internal reporting system. But I think what we tend to do, I don't know if it's a little bit extra, is that we base it on 4 or 5 characteristics. That's what we look at. We look at minor allele function in healthy individuals. We look at that percentage. We do, in addition to that, it's the second thing we look at is the type of mutation it is. Every mutation, like I know in India, which will lead to a frame shift, it's usually a very straightforward, pathogenic, but I think it's that one amino acid change, especially in these missense mutations, those become a little tricky. So when it comes to something like that, we tend to do a look at functional evidences. There are 3 in particular. We have a 3-level system, which is there internally. One is looking at functional studies which have already been done, which means they're papers which have Western blots or some sort of a picture showing that protein activity and kind of solidifying if it is pathogenic, likely pathogenic, or a VUS. We look at multiple case studies, preferably from different authors. And not from the same author, different families, familial studies, multiple families. So that's the second one. The third thing we do is if we look at anecdotal case studies, which are isolated, there's one-off rare cases, that's not something that we really depend on. But if it is there, we do assess that and try and understand its interpretation in the Indian population. And I think the fourth one, I usually put in silico predictors right at the bottom because it is a prediction model. It is it's a probability value associated with it. So we put that right at the bottom because some of these do tend to overclassify, like Barsome. We've in our experience, we have seen that there are certain differences, where something should have been benign and they give it a VUS, or something that should have been a VUS should be pathogenic. We've learned the hard way with obviously running multiple samples, but this is what we usually look at. And the protein sites, I think looking at the different domain sites are very, very important, especially in the BRCA1, BRCA3.
Yeah, and Dr. Anu, how do you approach the variant? So how would you approach this variant?
Hello. So yes, apart from what my fellow panelists have said, when I look at the variant, first I would think about, at the end of the day, what you want to know is the function affected or not? So yes, apart from computational predictions, sifting through algorithms, what I would do is I would look at where this variant falls within the gene domain or the structure. I would look at the 3D structure and see whether it is in a hydrophobic core or somewhere else outside, whether it is in a catalytic pocket, or does it affect any enzymes or the phosphoprotein linkages, because each, if it's BRCA1, the BRCT, the end domain would interacts with other phosphoproteins. So basically, I will look at where it actually falls, which will give me a rough idea as to whether I should dig more deeper into the functional part. Another thing, by one look, I can see this is asparagine to lysine. So I would look at the amino acid change. So not much is going to happen with an asparagine to a lysine change. So that will also give me a rough idea. So it is, I would keep a checklist and then go through everything, predictions, all sort of predictions, as you said, SIFT,
so,
do
you look at some clinical databases or something?
All, for that matter, all.
What are the clinical databases you look at?
Starting from ClinVar, taking it with a pinch of salt, of course, I would first look at when ClinVar.
So why do you say that? Why do you want to take it with a pinch of salt?
Because ClinVar updation is very, very important. Some are updated, yes, 2022, 21 is there, but some are 2016, so that is there. But then we found that when we manually annotate, there are a lot of differences between ClinVar annotations and our annotations using ACMG guidelines. So that is what happens with ClinVar.
That's a very good point, yes. That there is, because you can't just blindly trust ClinVar. That's what we have also realized.
Sure, it's true.
So, okay.
Members there, lots. It's like an exhaustive list.
Yes, I know it's difficult to recollect, but yes. And for the audience, I think we all follow ACMG and AMP classification, which divides. So there is a benign, a pathogenic, and there's an intermediate category, that is VUS, about which we are talking today. So in the benign, we have strong and supporting evidence, and in the pathogenic, we have supporting, moderate, strong to very strong evidence. So you can please correct me if I am saying anything wrong or you want to add something. So, and we look at the population databases as mentioned by Dr. Aparna, Dr. Vishal. Then we look at the computational and predictive data, the functional data, and the segregation data, which I think none of you mentioned. So that is also important, and I will just come to that. And in fact, I will like Dr. Anu to tell us what is segregation data.
Yeah, so especially when it comes to BRCA, HPOC and all that, well, it's very important that you look whether the variant is segregating alongside family members. So you look at other family members. Segregation, co-segregation just means that the variant happens to be present it's carried down in a way to say. So
do you do that commonly? What is
when I see patients, yes, when I see patients, I do take their families. So I do draw the pedigree charts, trying to link if they have data. Very difficult to get NGS data for every member of the family, leave alone the index. But still, I would ask direct questions whether they have a particular variant-related cancer in the family or not. So that is one way of looking at co-segregation, I believe. If I find evidence or some directive evidence, I would ask them to go back and get an NGS data.
Okay.
So that's
And Dr. Aparna, what is your experience with co-segregation?
Unfortunately, in India, I've really not had that opportunity because I don't think a lot of labs are doing that sort of testing where we are
What
looking
about
at
your experience abroad? So how?
So abroad, I think it is happening quite proactively. It really depends as to which lab you are tying up with. So I tend to go back to Ambry Genetics. So we have a tie-up with them. So if I do see a very strong family history where I see there is this mutation, it is a VUS, there is at least a high-risk family, I do try and have a conversation with all the family members and convince them to at least send us a sample so we can send it across to Ambry to see if it can be reclassified, or there is enough data supporting a reclassification. And we have been successful in 2 cases out of the hundreds of families that we see. 2 cases we've been successful in doing that because the entire family.
You do the entire NGS, or you just take that variant and do a Sanger sequencing?
No, just the area, the Sanger
Just the
sequencing.
way. And what about you, Dr. Vishal? So what do you follow at your institute?
We will say that, I'll say that we are just starting out. So our rate of VUS detection is 1%. So maybe a selection bias is there because we do in a very small cohort of patients.
And you started also.
Yeah, yeah.
Your rate will increase definitely.
Yes. We are on it. We have just introduced the panel, gene panels also. So we are doing the hallmark, and we have included all the 21 genes.
So what is your rate, Dr. Anu and Dr. Aparna? What is the rate of VUS in your respective places? Any idea?
I haven't calculated yet, but it must be a big number, I'm sure. I see a lot of VUS.
Okay. And Aparna?
In our BRCA, just BRCA specific panel, it's around 4.3% of VUS rates, but for our multi-gene panels, it's as high as 14.5%.
I think we have also had the same experience. So if there are lesser number of genes, so there's around 5 to 6%, most of the studies have reported. And if you have more genes, so the number of VUS increases. So, okay. Going to the next slide. So these are the population databases for the audience. So there are so many databases. So just Genome AD is the most popular one, then DBSNP and other. And then of course, as the panelists mentioned, the disease related databases, ClinVar, OMIM, and there are so many others again. So, and this particular variant was not found in Genome AD. So that is that it was not present in any of the population, and it was well covered by whole genome as well as whole exome sequencing, as you can see here. So this is the variant, and there are few pathogenic variants nearby, but this particular variant has not been reported before, and it is in the moderately conserved region of the gene. So that is another thing. So this was also reported in ClinVar, and as you can see, so there are 2 submitters who have submitted it, and it was uncertain variant of uncertain significance. They have classified it like that. And then there is a review status of this particular variant, which is 2 star. So there are these stars given, and about ClinVar, I will just like to say that you cannot just blindly, as Aparna mentioned, that trust these ClinVar submissions, because most of these submissions, in fact, almost 90% are from the clinical labs like yours and mine, and there are few from clinics and very few from researchers and all those things. And then these variants are starred. So more the stars, the more sure you are that this is a true variant. So and these are the classification, and there are expert panels which might be starring them. So if it is in a guideline, it's a clear-cut pathogenic or a benign one, then it has 4 stars, which is the maximum stars it can be given. Then there can be lesser star based on if it is expert panel or multiple submitters have called it the same thing, or it is just a single submitter. And when there is no star, so you need to be conscious, you cannot trust that blindly. So I can just get up and just submit any variant. So you have to keep that in mind. So it can be a false classification also. And if you just look at ClinVar, around 40% of all the variants are VUS. So we have such a huge number, which is around more than 760 million variants, which are VUS, and these need to be classified. So, and then as Aparna Anu said that about the co-segregation studies, these are family studies. So in this particular patient, there were two sisters, both of them had the same variant and they both had breast cancer, but other family members were not available for testing. So you cannot be sure that this is a SNP found in these two sisters or this is a pathogenic variant just with two siblings having them. You need more family members, more the merrier, and especially the ones who don't have cancer and are negative for these variants, they are more important than the ones who are positive. So you have to keep that in mind. And in India, and now with smaller family sizes, so these co-segregation analysis, if they happen, they're very good. They can turn a variant into pathogenic or benign, but they now practically most of us, it doesn't offer help in any ways. Okay, then as there are in silico models, like there are a lot of software generated models where you can predict the pathogenicity of a particular variant, but you have to remember that they are not considered functional assays. So functional assays are very important. So they can classify the variant either way, but they are not functional. You cannot bank on the result, just the result. You can take it into a consideration, but you cannot just bank on the result. And for this particular variant, there was a pathogenic prediction by various computational tools. So we used various computational tools and it was called pathogenic. So, and there were no publications, as Aparna was mentioning. So there were no publications for this variant. So, but you do look at publication for functional studies or if they've been reported before, because that helps you be more confident about the variant. But for this particular one, there were no publications. And if you just look at the ACMG classification, so this particular variant had a pathogenic supporting group because there are multiple lines of computational evidence, which so it falls in the category of PP3. And then it was pathogenic moderate, where it was absent in the population database. So there were these two criteria out of the entire these categories which we were looking for, which were present in this variant. So combining the rules, these are the ACMG rules of combining. So how you call pathogenic, I'm not going into the detail, you can refer to the paper. And then they are classified into pathogenic, likely pathogenic, uncertain, or likely benign or benign. And when all these criteria are not met or they are controversial, it is called a variant of unknown significance. And that is what it happened to this particular variant. It was PM2 and PP3 as mentioned, and it was labeled as variant of unknown significance by us. So these ACMG classifications are qualitative, and now there is a new publications and then a lot of data to convert it into a quantitative thing, because it is probabilistic and it can be converted. It is a highly probabilistic and it can be converted into a scoring model. And this is a very talked about paper. And in fact, this particular author, CN, also presented in this abstract about this particular paper, and it's been a lot talked about. And though we could not get the abstract, but I looked at the paper. So this is basically the same ACMG guidelines have been converted to a point system and which has been given. So presently we are not, but maybe in future we will be following this. So then coming to the next question. So what do you do once the patient has VUS? So what you tell the clinician and what you mention in the report. So what do you do? So first of you, Dr. Vishal, so what do you do when you get a VUS?
We got few of them. So we discussed the case with the medical oncologist that this is we have got. And then we do counseling of the patient also. We have done for, I think, 2 cases we got. So
what kind of counseling? So what do you
family history, okay. And any other, are there any tumors in any relatives like that? But surprising we didn't find any because we were only 2 cases.
That is usually the case. You don't find anything.
Find any case history.
Yes.
So,
And even if you have a relative who's having that, but the same thing is there. So you don't have enough family members to call it a definitive pathogenic. And at times you can even offer these patients treatment. These PARP inhibitors can be offered if they turn into pathogenic. You're feeling it so strongly clinically that they are pathogenic, but you can't just write it there.
yeah.
So any other experiences of similar or something else you'd like to share about VUS clinically, how the doctor reacts or how the patient reacts when they get VUS? Aparna and Anu, anything else you'd like to add to that?
I was just going to add that with us, so I being a genetic counselor, we've actually got these guidelines that have come on from the National Society of Genetic Counseling, which helps us actually dealing with these cases, because it's not just sometimes one patient or two patients, it can be a whole family. But we see a very strong family history where maybe they've not done the genetic test, but we've done a couple of siblings and they are these VUSs. And again, they don't want to go in for studies. So I think dealing and tackling with VUSs, especially from a clinical aspect, is slightly tricky. So if we just remove the treatment factor and we look at the management and surveillance, so what I say is that for a family that has got a really high risk family, they fall within the quintessential inheritance pattern of being high risk, they've got all the red flags. Over there, I do think that we should go ahead and get everybody, tested, understand who is a carrier, and treat them as a positive patient without offering risk-reducing surgeries, but at least something like normal mammograms and ultrasounds. Basic maintenance surveillance is something that we very strongly are starting to advocate, especially in those high-risk families.
So how often do you review these VUS?
At core, every 6 months, we go back to our databases, and we also tell patients if they've tested elsewhere and come to us that in 6 months, kind of just nudge us again and send us your report to see what the status is, but every 6 months.
Okay, and Anu, what about you? So is it same at your place or it is different? Or you follow?
No, we've had 2 instances. Honestly, VUS is a nightmare for a clinician. So especially the
most malignant diagnosis. That's what I've been told.
Yes. So, but then I've heard, I would use this platform to say that I've heard clinicians treating VUS. I do not know why, but please don't do that if somebody's doing it. Anyhow.
Yeah. In fact, today, I think half an hour before the session, I received a call from our breast surgeon. So she said that there's a patient who has got VUS and they want their daughters to be tested for VUS. So that is a very common thing, request I get, because there are no other family members available and they want the VUS to be tested in the daughters. So I keep on telling them, so you will not be sure, it's unnecessary, this thing, but the people don't stop. They want to get themselves tested for VUS.
Exactly. So what we would advise is, all right, if it's like we had a colon, 3 family members having colorectal cancer and 1 brother turned up with an MSH2 VUS. Okay, so another breast with a BRCA1 VUS. So all right, you go back, as Dr. Aparna said, 6 months. Every 6 months you look up. I would jump it up to maybe 3 months, just for the sake of to be on the safer side. So keep looking at if the annotation has changed, the classification has changed, and put the patient on a very wide follow-up. Just see how he's.
Another thing, so this ClinVar, if the variant is in ClinVar, has the option of notifying. So you can give or you can teach the patient. I think this is what the people in abroad do. They can teach the patient to, if the variant is there in ClinVar, to click on that, so that the patient, if the status is updated, the patient receives the email. So that is another thing that can be done. So
that's an excellent point.
Yeah. So if it is there, so you can do that. And also I would like to know from all of you that do you report it like if it's a VUS and a computational model has, like in this case, has called it pathogenic. So do you write it somewhere in your report that it's a VUS, but the computational methods are calling it as pathogenic? So just for a heads up for the clinician. So do you do that?
Yeah.
You do that? And Vishal, what about you?
I didn't get it, but definitely I will write a comment about it.
Yeah. I think at least you should write it somewhere very small thing, because it is difficult for the clinician to answer the patient, but you can write it. There are no recommendations as such that you write these about these in silico predictions, but you can just at least you can write your criteria based on which you called it US. So that's what we can do. So there is one thing which will change the BUS either to benign or to your malignant. So these are the functional studies. So what are these functional studies? So you go first. So what are these functional studies?
I'm sorry, I didn't hear your question.
I think some disturbance.
Yeah, sorry. Could you please repeat?
No, ma'am, your voice is breaking actually.
Maushmi, you can switch off the video, then maybe you will get a bandwidth.
Okay. I think there's a
No.
problem. So
I think it is a problem with the internet.
Okay. Thank you for the suggestion.
It is a problem with the internet.
So my video is stopped, but
yeah, but still the voice is breaking.
I think that charge is going.
You can connect with phone or something. I mean, hotspot.
Is it okay now?
No.
No.
Phone or hotspot.
Let me continue the discussion. I think till I have started the hotspot also. So my question is that functional studies will alter the fate of VUS. So either they'll shift it to a benign or a malignant category. So what are these functional studies? So any one of you, Vishal, can you take this question? Hello?
Breaking.
Can you hear me?
Your voice is breaking, ma'am.
Yeah, can you hear me now? Hello?
Hello?
Yeah, can you hear me now?
Yes.
Hello? Yeah, what are functional studies?
Yes.
Hello, Dr. Vishal. The question was, what are the functional studies?
What are functional studies?
Okay.
Can you hear me?
Hello, Dr. Vishal. The question was, what are the functional studies?
I think Gurudev.
Yes, sir.
I think let Aparna or Anu summarize and speak a word about the functional studies. Okay. I think Maushmi is finding it very difficult to connect. So Aparna can summarize and speak and say, and I think even your voice is breaking. And I don't know if my voice is also breaking, but
so your voice is okay.
So my voice is okay, but your voice is not okay. So you please get your internet connection also set right. And Aparna, in the meantime, you can summarize something about the VUS.
Everybody's.
So I think Vishal, please, you can mute yourself, and Gurudat, you mute yourself and let Aparna speak.
I was just going to just very quickly to summarize. I think with VUS, functional studies. There's something up with everyone. Okay, am I audible? Yeah. Okay.
Yes.
No, I was just going to say that with VUSs in particular, functional studies, these are, as it's very crisp and clear over here, that these are different testings that are done in a clinical laboratory setup. And this is what we actually like referring and going back to help us understand as to if a potential variant should be classified as benign or pathogenic. There are different methods of doing them. We do it in vivo and in vitro. Again, we're looking at different things if it's in vivo, in vitro. I don't remember them all the top of my head. I think Dr. Anu would be better equipped answering that. But we look at like the mRNA splicing sites, we look at the protein expressions, and looking at this kind of information, we help categorize and reclassify these VUSs as either being benign. Yes, there you go. As either being benign or pathogenic. These are essentially quantitative analysis. And it is using this, there are three, and this is again gone and become a little bit more advanced and complex, where we look at, I think the next thing is multiplex functional studies, where we're having the opportunity to look at, where we collect and curate functional data from various, number of genes, a number of sites, and we're kind of doing that all together. And please someone correct me if I'm wrong, but you're kind of getting a full-blown analysis at one shot, a multiplex testing that is being done, where you have a larger cohort of patients, a larger cohort of VUSs that actually can be reclassified. And in particular with a BRCA1, BRCA2, the TP53 genes, there are all these different methodologies. So VUS, which is considered to be very malignant today, and I understand because it's stressful in our clinics, but the idea is going forward with advances in technology. We do have different predictor model software that is available, which obviously needs to be implemented into our clinical practice, and it has to be done hand in, the clinician and the laboratory kind of have to do it together. And yeah, that's all I can think of at the top of my head, but anybody else? Anybody else wants to take over?
Can you hear me now?
Yes,
Am I audible?
I have to run for another.
Okay, Anu, can you add to that?
Yes. Under biochemical assays, I would add mass spec, which is very important. It's used in certain clinics in the, especially in Taiwan. I have had collaborative clinicians use it, not for VUS, but post erlotinib EGFR assays. But anyhow, that is something that would come up in the future using mass spec for protein quantification. Another thing which I am very interested is the model organisms. So in IGIB Delhi, they have a zebrafish where using the CRISPR-Cas9, you can introduce variants and see. So if it's BRCA1, 2, you can always look up and see if the DDR is intact or not using such model organisms, which are very close to humans rather than cell-based assays.
Yeah, rightly said. In fact, can you see my slide moving? Is it moving? So the problem with these assays is that, yes, there are a lot of assays and at different levels. So you need to check something at different levels. So, but the problem is the quality. So most of them have been done in research settings and they may not have such a good quality, and you may not be very sure about the result of the assay because they're done in some lab and God knows what validation that person did or how many controls they had and what so. So that is it is very difficult. So what is new to this is that now we have multiplex functional assays. So there are thousands and thousands of variants which can be checked simultaneously. So anybody who will like to volunteer, Vishal or Anu would like to volunteer. So what are these multiplex assays? Can you hear me? I think
I'm not well versed with multiplex assays. I've just read about dissection.
Yes, I know this is a new thing, so I have also read it in the papers. So
But something that caught my eye was the caveat of using haploid cells for these assays, which kind of puts you in a difficult spot because you're just looking at one copy rather than two copies. So anyway, we have to use what we have. Compared to other models and predictions, they are obviously going to be much better.
So actually what is new in these assays is that the variants can be introduced. So earlier there were these transgenesis and there were other methods, but now we have CRISPR. So by CRISPR, we can just edit, and I think there is another talk on CRISPR, so I'll not go in detail. So you can introduce these variants and you can have thousands of variants introduced in one go. And then you can look at the effect of those variants by cell sorting and all that. So you can read about them, and you can see if there is a loss of function or if there is a gain of function by a particular variant. Okay, so actually I think my slides are not moving, but I wanted to show you that there was this one particular variant in the BRCA, which I saw in the database, which has been shifted, which you could see at the same position. If the mutation was different, you could see, okay, it's come here. So these are the mutations, this is genome editing, and these are the various methods by which the mutations can be induced in cell lines or whatever, and then the effect of these mutations can be seen. Okay. Okay, and coming back to the database, so I have seen this particular mutation in the database you can see by the functional score of these multiplex assay that it is a loss of function, or it is a normal function is retained, or it is an intermediate category. So till now there are 3 genes for which most of the VUS have been sorted. So one is the BRCA1, the other is TP53, and the third one is P10. So I wish I could show you my slides, they are not moving. So they have been sorted till now, and I think the prediction that after in 2030 that most of the VUS will be finishing might come true. We may not finish it completely, but most of it will go. So, and any other thoughts from any one of you, Vishal, and you'd like to say something? What would happen in future? So one is that most of the VUS will go. So anything else you feel?
I'm sorry for intervening. Need to conclude this panel.
Yeah, I'm just finishing. This is the last thing.
Make a multi-institutional study and make a common database, then we will be able to better analyze these VUS in India also, and in different ethnic groups. And the problem of affordability is also there, because all the patients, because we are a trust hospital, so there will be some limitations to do this NGS in all the cases.
Yes, definitely. Those are the problems. These are real world problems.
Yeah. That is why we are lagging behind, because of these problems.
Yes. And I also feel that probably there will be polygenic scores. So these are the genes you can see, BRCA1, TP53, and P10, which have been, there are around 20,000 variants which have been categorized, and 49% of BRCA1 VUS and 69% of TP53 and 15% of P10 VUS have been reclassified. So you clearly know that this is benign or this is malignant, and these are databases available for BRCA1. It is available in the University of Washington. You can go there and see if you have some variant, so the functional score, and put it to your ACMG classification. I can't move it. So I like to thank all the panelists, and I'm very sorry for what happened. And I think my internet is back also now. So thank you, and for giving me this opportunity. Okay.
Thank you.
Thank you, Dr. Rashmi, Dr. Vishal, Dr. Aparna, and Dr. Anu for the academic feast and this mind-blowing discussion on VUS and the future of VUS. So with that, we end the session. Okay, we have only one question by Dr. Mehta. Do you review the status of VUS periodically?
I have taken that question.
Okay, you have already addressed this question. So there are no further questions. So thank you. And with that, we come to the end of this session. So it was an academic feast, and we all know there are a lot of these genetic information which is available. What is important from patient point of view and what will alter patient therapy is very, very important to know. And I'm sure with these newer studies coming up, we'll be more wiser in future. So thank you. I thank the organizers for this opportunity. So thank you very much. I hand it over back to Dr. Gurudat.
Thank you, sir. Thank you, Dr. Rajit Tangri, for conducting an excellent first session. Now I invite Dr. Reena Bharadwaj. She is Senior Consultant and Clinical Advisor of Lab Sciences at Indraprastha Apollo Hospitals, Delhi, to conduct the second session.
Thank you, Dr. Gurudat. Am I audible?
Welcome, madam. Yes. Yes, ma'am.
Okay. So at the outset, I'd like to thank the faculty and the organizers for giving me the privilege to chair this session. And we will be running through certain contemporary issues and a lot of recent advances in breast pathology in this session. In all, we have 7 speakers who have been allotted 7 minutes each, followed by a panel discussion for half an hour. All questions, as in the previous session, will be addressed in the chat box with the speaker identified to whom the question is addressed. And without wasting much time, we'll move on to the first speaker we have is Dr. Shivani Sharma. She is the Lab Director and Vice President of Pathology Services Core Diagnostics, Delhi. And she will be speaking on a topic which says clinical utility of molecular tumor profiling results from the randomized trial SAPHIRA-2 of breast. Over to Dr. Shivani, please.
Good evening. I'm Dr. Shivani, and I'll be presenting on the clinical utility of genomic profiling in patients with metastatic breast cancer, the results of randomized trial, which was presented by Fabrice Andre. So the background research questions for this trial and the study were that, is the targeted therapy effective in metastatic breast cancer? Second, how to interpret a genomic report? Are there predictors of drug efficacy? Which technology for genomic profiling is the best? And what are the molecular characteristics of cancer? So the SAPHIR-2 breast program had a study design which included patients with metastatic HER2 negative non-overexpressing breast cancer, patients resistant to endocrine therapy, which were previously hormone receptor positive, and previously treated with a maximum of 1 line of chemotherapy. The specimens that were included were either frozen specimens or these were the FFPEs of fresh biopsy or a biopsy less than 12 months. Interestingly, also the ctDNA sample. The technologies that were included were the next generation sequencing and the copy number variation studies. This group of patients were given chemotherapy and these patients who were found to be stable and responded entered the randomized trial. But one thing that was common was that they had a targetable molecular alteration in them. So 9 targeted therapies matched to genomics were compared with the maintenance chemotherapy, but they were divided into 2 specific trials. PIK3CA was given a separate specific trial with the patients who were treated with the alpelisib, and it was compared to the maintenance therapy. And the other group had the 8 targeted therapies matched to the genomics. A process of hierarchical testing was followed because in the first group, the inclusion was done for the SCAT1-2 category patients, and the progression-free survival was studied in this group. And the second was the intent to treat population, which included around 238 patients. This brings us to the question that what is SCAT classification? So SCAT classification is an ASMO unified framework of actionability where the clinical evidence defines the tier in which the molecular alteration with the matched drug lies in. So tier 1 is the alteration drug match, which is associated with improved outcome in clinical trials, whereas tier 2 is the alteration drug match, which is associated with an anti-tumor activity, but the magnitude of the benefit is still unknown. But it is defined that beyond tier 2, there is no anti-tumor activity that is seen. So the hypotheses that were brought out were that the targeted therapies matched to genomic alteration in SCAT1 and 2 had a hazard ratio of 0.51 and a minimum of 85 events were necessary. Whereas in the second intent to eat population, the total of 205 events were necessary and a hazard ratio of 0.66 was obtained. There was a separate arm for immunotherapy in this trial. The questions that were answered were that has genomic profiling improved the clinical utility in the patients with metastatic breast cancer, and how do we interpret it? So a total of 1,462 patients were included in this study from a time period of 2014 to 2020, and it was seen that a targetable alteration was seen in a total of 646 patients, which were further divided and into two basic groups. First was the pooled analyzed population, which was 238 patients, and of which had only 115 had the SCAT1-2 category. Results. The first result that was seen was that the median progression-free survival was 9.1 months in case of targeted therapies of SCAT1-2 population. And hazard ratio that was obtained was 0.4, and this was statistically significant. When the subgroup analysis was done, not major interaction p-value was seen, but yes, there was a certain kind of changes in the activity of the various drugs that were used that was obtained. As the first step became statistically significant, the second step was done in the hierarchical testing, and the overall population was studied, where the progression-free survival was increased to 5.5 months, but it was not statistically significant with the hazard ratio of 0.7. But interestingly, in the subgroup analysis in this case, it was seen that the non-SCAT1-2 population had a hazard ratio of 1.15 and SCAT1-2 had 0.48, which made this interaction p-value statistically significant and also helped in the conclusion that the genomic alteration is going to help in the targeted therapies in those patients which come in the SCAT1-2 category. The second question was that what is the genomic landscape of metastatic breast cancer, which we know is really wide, but the stress was laid on the copy number analysis. And it was studied that in the patients who had already obtained CDK4/6 inhibitor and were resistant was the group which was laid more importance for. And this included a group of 102 patients. In these patients, it was seen that 13 genes were more frequently altered, and of which the 10% was just the CDK4 inhibitor amplifications. So CDK4 amplifications is seen more commonly in this subgroup of patients. The third question that was being answered was that can we identify new genomic markers of drug sensitivity? So it was seen that the loss of heterozygosity of BRCA, loss of second allele, and the homologous recombination deficiency score in the patients who had BRCA mutations, the progression-free survival was way more, who were treated with the drug olaparib. So the study concluded that genomic profiling has clinical utility in patients with metastatic breast cancer only when they are studied and in a unified framework of actionability, especially in the SCAT categories. Genomic reports must rank the genomic alterations according to this validated framework of actionability. This study had limitations because the study does not assess the technology to perform genomic profiling, and also the study cannot directly assess the impact of genomics on the overall population of patients, since only patients presenting a genomic alteration were randomized, which was quite small in number. A subset of patients who became resistant to CDK4/6 inhibitors present with CDK4 amplification in their tumors more commonly. Homologous recombination deficiency and loss of heterozygosity are associated with longer progression-free survival in patients who get treated with olaparib. Thank you.
Thank you, Dr. Shivani, for giving such an insight into the randomized trial of SAPPHIRE-2. We'll now move on to the next speaker. The next speaker is Dr. Sudha S. Murthy. She is the Director, Clinical Support and Senior Consultant, Datar Cancer Genetics at Nashik, and she will be talking to us on genomic markers, novel approaches, and targets. Over to Dr. Sudha.
Thank you, ma'am. I thank the organizers. I hope I'm seen. I thank the organizers for the opportunity. Dr. Shivani has set the stage for me, and so it becomes easy for me. I'm sorry. Is my screen visible?
Yes, it is visible.
So this topic was presented by Dr. Daniel Stover from Ohio State University. And we all know Dr. Shivani had alluded to the SCAT scale, and what was initially around 5 to 6 years ago, many mutations were there, but we did not have many therapeutic targets. But in recent times, we have seen lots of therapeutic data coming in, and we have seen in our previous talk that it has relevance to the SCAT scores. So the difference, so this talk is pertaining to the ctDNA advances. So we know that there are different technologies that have been adopted. ddPCR was the first one which was brought in, but this had only single target, and then targeted panels. Now we have quite a few CLIA-based assays in targeted panels. And then we have also seen the adoption of whole exome sequencing, whole genome sequencing, and of course, the recent times we have seen Signatera, which is tumor-informed ctDNA sequencing for ascertaining the MRD status of the patient. Now, in this session, we have an abstract on shallow whole genome sequencing. Before moving on to the abstract, we would try to understand what is shallow or low-pass whole genome sequencing. This is cost-effective, high-throughput DNA sequencing technology, which is used to accurately detect genome-wide genetic variations. It uses very low coverage at 0.1x whole genome sequencing, and some investigators have utilized 5x whole genome sequencing. It depends on the imputation of sequence data to bioinformatically fill the gaps using publicly available reference data. And this is how people have found this useful. So this is again a publication by the speaker, Dr. Stover, who had shown that the tumor fraction, when it's more than or equal to 10% in the first draw, that is in therapy naive cases, it is associated with shorter survival median, median being 6.4 months versus 15.9 months. So therefore, he has shown that an algorithm, ICOR-CNA, to profile the somatic copy number alterations and quantify the tumor fraction via low coverage whole genome sequencing of the cell-free DNA without a priori knowledge of the tumor mutations. Now, this is the first abstract which talks about whole genome sequencing based circulating tumor DNA profiling for molecular characterization and therapy response prediction. It was for over a period of 3 years. It was a prospective study in treatment naive metastatic breast cancer patients. The study cohort was 207, and they used low pass genome sequencing using 5x. And the I-scores were determined, which is the metric of copy number alterations in ctDNA. They have shown strong concordance of ctDNA with tissue. And what was interesting here was the I-scores were significant in triple negative patients and also hormone receptor positive and HER2 negative patients. It also was higher in patients with visceral metastasis, especially lung, liver, and lymph nodes. So they said that the I-score has a prognostic relevance, as has been described in other publications. Also, the ctDNA metrics have some predictive benefits as well. So the total, in the triple negative breast cancer, using shallow whole genome sequencing, the HRD score was found to be high as opposed to the other molecular subtypes, and also high HRD in patients with TNBC showed higher response rate and reduction of tumor burden on first or second line platinum-based chemotherapy. Now, the next, they summarize that the shallow whole genome sequencing based ctDNA analysis is a robust tool for non-invasive genomic assessment, response prediction, and HRD estimation in metastatic breast cancer. Also, it identified resistance factors for CD4/6 inhibitors, BCL6 for innate resistance, FGFR1 and MYC amplification for acquired resistance. The next abstract was a study cohort, which is a retrospective study, multi-institutional study, which had 1,047 metastatic breast cancer patients. ctDNA analysis was done before treatment. It was over a period of 5 years, and the focus was on luminal light cohort. The aim was to study the interplay between ESR1 and PIK3CA codon variants. As has been described, PIK3CA mutations were detected in the majority, which constituted 31%. ESR mutations, especially in resistant setting, also were detected in 24 patients. And they also described what were the codons which were most commonly observed in both ESR1 and PIK3CA. Also, they looked at the SNVs and CNVs. They have studied the association of these genetic alterations with reference to the metastatic sites and tried to find a correlation of the codons with the metastatic site. Now, looking at the Kaplan-Meier curve, they said that ESR mutant and PIK3CA mutant patients and ESR mutant and PIK3CA wild type patients had worse survival as compared to the other groups. So they said that ESR1 and PIK3CA variants, together with alterations in oncogenic pathways, can impact the biology of metastatic breast cancer and help in selection of patients to be treated with SERDs and PIK3CA inhibitors. Now, the fourth abstract was highlighting the neurotransmitters and neuronal signaling in breast cancer. And they have shown that this was a cohort of, I don't know whether you are able to see this, 6,464 patients with NTNS pathways enriched in the IDCs, especially the triple negative breast cancers. And HER2-neu was the HER2-neu enriched groups were low for the neurotrophic factors. They had concluded that cancer neuroscience is an emerging field, and evidence for role of nerves or neuronal signaling in the tumor microenvironment probably would be playing a big role in identifying targets and the pathways. So within breast cancer, specific subtypes appear to have distinct pathway activity. So to summarize all of these, the discussion was mostly on the types of ctDNA testing and the role of shallow whole genome sequencing and deep whole genome sequencing, the landscape of mutations in metastatic breast cancer, and the relevance of cancer neuroscience in breast cancer. What do I feel my take in the Indian scenario? I think we have to start adopting panel-based testing instead of single gene testing right away. Depth of sequencing for ctDNA is a very important issue, which we are seeing a lot of variation. And if possible, wherever feasible, we should sequence all breast cancers, at least at metastasis, to understand what is our patient profile. Thank you for a patient hearing.
Hello. Thank you, Dr. Sudha. That was indeed a good insight into various new genomic biomarkers, and I'm sure we are in for revolutionary targets. With that, we will move on to the next speaker, Dr. Malini Goswami. She's the consultant histopathology at SRL Diagnostics, Gurugram, and she will be talking on single cell analysis of circulating tumor cells. Thank you.
Today I'll be talking about single cell analysis of circulating tumor cells, also on the topic of epithelial mesenchymal transition, or EMT. EMT is basically a physiological switch in cell fate whereby immobile epithelial cells acquire migratory properties of mesenchymal cells. Absent activation of EMT has implicated malignant transformation.
Dr. Malini, put your screen on slideshow.
Has been validated using histology analysis owing to the presence of stromal cells, strongly positive for mesenchymal markers, and thus the detection of epithelial tumors.
Hello.
Transient mesenchymal.
Hello. Ma'am, can I interrupt you?
The ability to
Dr. Gurudat?
Yes, ma'am.
Is she audible? I can't hear her.
No.
She's not, huh?
No.
Rina, why don't you go to the next person and then let Malini come back after?
Okay, sir.
After the next speaker.
I'll do that. Due to some technical glitches, we're moving on to the next speaker, and the next speaker is Dr. Vinita Pant, who is the Senior Consultant in Pathology in Center for Oncopathology at Mumbai. She will be talking to us. Vinita, are you in here?
Yeah, I'm there. Thank you, Reena.
Yeah, and she'll be talking to us on novel epigenomic targets in triple-negative breast cancer. Over to Dr. Vinita.
So I thank Dr. Mehta and Dr. Gupta for giving me this opportunity. I'm sharing my screen. Is it visible?
Yes, you are visible, but we are not seeing your slides as yet.
So can the IT team start it for me? Can you see my screen now?
Not yet.
Now? I see the presentation.
I will let you know when we can see it. Can the organizers please help us?
Ma'am, I have shared your slides.
Now,
You just have to say
now
next
we can
slide.
see.
Can you see this novel epigenomic targets and
Yes,
TNBC? Okay. Can you see the movement of the screen?
Move to the next slide. We can, yeah.
Okay. So I'll be discussing novel epigenomic targets in triple-negative breast cancer presented by David Sescon. I would like to say that this entire presentation is very challenging for me because I deal with histopathology, immunohistochemistry, and molecular biology is a complex subject and pretty theoretical as far as I'm concerned. But I would like to at least share with everybody my understanding of the basic principle. Now, when I talk about epigenome, I would like to say that what is my understanding of epigenome before I go on to the epigenomic targets? It's that since genome is DNA required for building and maintaining the organism, epigenome is above the DNA, meaning it's a description of all the chemical modifications of DNA and histone proteins that regulate the expression of genes within the genome. So there's no change of the DNA sequence, but it determines when it is switched on and off. And this is a short cartoon which I have tried to illustrate. So what are the epigenetic alterations? Now, normally in the cell, epigenetic alterations play a role in self-renewal, directional differentiation, and development, but they also play an important role in malignant transformation and progression of the tumor. And what are these? The most important epigenetic alterations are DNA methylation and histone modification in the form of acetylation and methylation. So these are the three very important epigenetic alterations which we come across very commonly. There are others like non-coding RNA regulation, chromatin remodeling, and RNA modification. Now, what is important, which I've tried to understand, is that the DNA methylation, these are the methyl transferases, and those are the acetyl transferases, and again the methyl histone acetyl transferase and histone methyl transferase. So this is the reaction which is causing the problem. So all therapy is intended to inhibit those reactions. So what do we have here? In triple-negative breast cancer, right now, these are the four main principles on which they are treated. I will not go into that, but I'll talk of the epi-drugs. Now, what are epi-drugs? Now, if you look at this part of so this is the epigenome, that is the DNA is bound around histones, the histone proteins, and this is where these are the four reactions: acetylation, methylation, to lesser extent phosphorylation, and ubiquitization. DNA modifications in the form of methylation, RNA methylations. Now, if you look at the targets, these are all the enzymes, that is the histone acetylations and the protein methylations. But what the drugs are their inhibitors. These are the two drugs which they have, what I've underlined, these are two drugs which are against the methyl transferase 1 and 2. Now, I'll try to explain what these are. Now, protein arginine methyl transferase, this is important. There are 9 of these, and they are important and expressed in cancer. So, inhibition of these protein arginine methyl transferases would help in blocking the progression of the cancer. And of these two drugs which I had shown earlier, these are being used, and right now the status is that in triple negative breast cancer, the cohort has not been reported, and the trials are mainly on ER positive disease. And mostly what I've understood is that the PRMTI1 inhibitor has strong and 5. This is the PRMTI5 inhibitor has strong anti-cancer activity, and both these PRMTI1 and 5, they synergize with each other and their activity. So if you have a PRMT5 a marker which can detect this PRMT5 inhibitor, that would help you in stratifying patients who could benefit from these therapies. And there's a MTAP gene deletion which impairs the PRMT5 activity, which causes the accumulation of a substrate, and that serves as a biomarker. So that's the principle behind using these inhibitors. However, these are very toxic, and it's more common. The principle of epigenetic therapy is more common in combinations. So in combination with chemo or targeted therapy, they are trying to target DNA damage response with BET inhibitors. Now, as already, now we all know the principle behind why PARP inhibitors are used. So they are used in genetically mutated BRCA patients, where they use the, so there are 2 pathways to repair the DNA, and in BRCA mutated patients, this homologous recombination pathway is compromised. Hence, if you compromise the PARP pathway also, then it causes what is called a synthetic lethality. So, but this advantage, if I may say so, is only to patients who have germline BRCA mutation. Even methylation of BRCA can contribute to BRCA-ness, but in studies it is seen that if you use carboplatin, the patients who got a germline BRCA mutation, they do better than patients who have a BRCA methylation. So that kind of limits the number of patients that can take advantage of PARP inhibitors. So what is trying to be achieved is that you try to identify PARP inhibitors and epigenetic drug combinations and compromise the homologous recombinant pathway. So how they do that is, one of the drugs they've identified is BET. So they're basically strategies to enhance response to the PARP inhibitors in primary and acquired homologous recombinant proficient tumors. So that would be major advance in cancer care. And how BET activity, repress BET activity, it reduces this is not hormone receptor, it took me some time to understand that. This is basically the homologous recombinant pathway. So repressed BET activity will reduce the homologous recombinant pathway and enhance the PARP inhibitor induced DNA damage in the cancer cell. So we are trying to titrate that. So like I already said, BET inhibitors, they are play a key role in cancer and even promote expression of oncogenes, in addition to impairing the homologous recombinant activity. So this is to show how they show synergy. So right now it is in the phase 2 trial, and what I've understood is that the basic problems lie with the therapeutic toxicity. So, and plus there are other DNA repair targeting therapies. So basically to take advantage of what is the synthetic lethality. In acquired drug resistance, again, the same principle, like I said, in epigenome, as a tumor goes through epigenomic modifications, it acquires drug resistance with the help of these epigenomic modifications. Now, how we try to overcome that resistance is by reversing the epigenomic modifications. So again, there are trials which are in process to create a druggable epigenomic genetic vulnerability. In combination with now for immunotherapy, this is complex and more, it's under, really speaking, I did not really see any concrete take-home message in this, except that it is being tried. So I would like to summarize by saying that's the summary that the author has given, saying that TNBC is a challenging disease, and the challenge lies in the fact that they don't respond to hormone receptor treatment, and chemotherapy acquired resistance is a problem. Monotherapy epi-drug approaches, like I said, is under evaluation. They have the problem of toxicity. Drug resistance is the main feature of TNBC, and this is the main area where the epigenomic pathway can be utilized to our advantage. Epi-drug combinations are of interest. Like I said, toxicity and tolerability are the problems. So my take home in this is that epigenomics, it programs the cancer cell to its advantage. And what you do by, what we are trying to do is we reprogram the cancer epigenome to becoming a promising target for treatment development and development of drug resistance. Thank you.
Thank you, Dr. Vinita. That was indeed a very complex topic, and we really don't know what lies in store for us in the future after these trials. And do we go back to Dr. Malini? Are you here, Dr. Malini? Well, if Dr. Malini is still not on board, we'll move on to the next speaker, and I would request the speakers to stick to their time because we are running grossly behind time. The next speaker, Dr. Malini.
Ma'am, it's a recorded presentation.
Okay, but
He's trying to put it.
So we'll wait.
Yes, ma'am.
Hello everyone, I'm Dr. Malini Goswami. Today I'll be talking about single cell analysis of circulating tumor cells and also on the topic of epithelial mesenchymal transition, or EMT. EMT is basically a physiological switch in cell fate whereby immobile epithelial cells acquire migratory properties of mesenchymal cells. Aberrant activation of EMT has been implicated in malignant transformation. Owing to the presence of stromal cell cervix, which are strongly positive for mesenchymal markers, and thus obscuring the detection of epithelial tumor cells transitioning to a mesenchymal state. Demonstrating the contribution of EMT to cancer metastasis thus requires the ability to isolate cancer cells. So now we'll talk about circulating tumor cells. These are basically cancer cells that split away from the primary tumor and appear in the circulatory system as singular units or clusters. They represent an intermediate stage of metastasis and are very rare. Now,
Just let me join again.
this is the figure depicting epithelial mesenchymal transition. So, EMT of individual cells within the primary tumor leads to their intravasation into the bloodstream, survival of such CTCs within the bloodstream, and finally their extravasation at different sites where mesenchymal to epithelial transition or MET culminates in their proliferation as epithelial metastatic deposit. So, technologies for the enrichment and isolation of CTCs have ranged from simple to the sophisticated. Peripheral blood mononuclear cells can be enriched with chemical lysis of RBC, leaving the rare CTCs intermixed with mononuclear immune cells. The majority of CTC enrichment methods is based on immunoaffinity separation techniques or antibody-based methods of CTC isolation. So there are different First one is the micropost chip, second one is the herringbone chip, and the last one and the newest one is CTC iChip. CTC iChip is basically a microfluidic device with a two-stage separation process.
To the next speaker, and the next speaker is Dr. Bhavna Narula, Senior Consultant Histopathology at Max Super Speciality Hospital, Delhi. She will be addressing the topic of molecular heterogeneity in HER2-positive breast cancers. Can outcomes be predicted? Indeed, a very important topic. Over to Dr. Bhavna.
Hi, good evening, everybody. First, I would like to thank Dr. Gurudat and Dr. Anurag for inviting me here. And going in tune with the treatment of breast cancer in the new millennium, the topic I am going to discuss is dissecting the heterogeneity of HR-positive, HER2-positive breast cancers. I'm going to cover the topic under the following headings. Are the slides moving, ma'am?
Yes,
okay,
they are moving.
Okay.
But
So
put the PowerPoint mode. Use the PowerPoint mode.
Just a second, sir. Is it okay, sir, now?
Yes, it's fine.
Okay, ma'am. Okay, thank you. So I'm going to cover the topic under the following headings: ARPR HER2 crosstalk, response and survival implications of HR status in HER2 positive breast cancers, the intrinsic subtype within HER2 plus stratified by HR status, the ERB2 gene expression levels, intratumoral heterogeneity of HER2, and properties of HR positive, HER2 positive tumor microenvironment. So the CALGB 40601 trial, the distribution of ER and PR within the HER2 positive patients, 69% patients are triple positives with all three HER2, ER, and PR positive, followed by 29% of tumors which are positive for HER2 and ER but negative for PR, and a very minor percentage of 3% is positive for HER2 and PR and negative for ER. So the ER and HER2 molecular crosstalk, as we can see in this diagram, there is a bidirectional crosstalk between ER and HER2 proteins, and HER2 ER enhances HER2 activity, and HER2 in turn through the downstream pathways of AKT and MAP kinase enhances the ER activity. So as we can see in this graph, in the cases, some ER positive, HER2 positive breast cancer cells might be primarily driven by ER and thus are intrinsically less sensitive to anti-HER2 treatment and possibly sensitive to endocrine therapy. Next is the response and survival implications of HR status in HER2 positive breast cancer. In the CALGB 40601 study, which was a randomized study, and 305 cases of HER2 positive patients were taken of stage 2, stage 3, and they were randomly allocated to either weekly paclitaxel and trastuzumab, weekly paclitaxel, trastuzumab or lapatinib, and trastuzumab and lapatinib. As we can see in the graph on the right, the hormone receptor negative patients had a high response of 79% with the dual anti-HER2 therapy versus the hormone receptor positive. Same with PCR and RFS relationship based on HR status. As we can see in the middle graph, the cases which are hormone receptor positive, we couldn't find any relationship between the RFS and PCR, whereas the significant relationship was found between hormone receptor negative cases we could predict the RFS by PCR status. In the metastatic setting, HR negative disease shows higher relative benefits from anti-HER2 therapies. As we can see in the various anti-HER2 trials, the hazard ratio for PFS and OS is higher in the HR positive arm compared to the HR negative arm. Next, I come to intrinsic subtype within HER2 plus stratified by HR status. The clinically HER2 plus tumors according to PAM50 intrinsic subtypes, as we can see in the middle figure, which is HR positive and HER2 positive, the proportion of the luminals, which is in blue, is way higher than the HER2 enriched type, whereas in HR negative and HER2 positive cases, the proportion of HER2 enriched is higher than the luminals. The distribution of the HER2 enriched, as we can see in the figures on the right hand side, from triple positive, which are positive for all three, HER2, ER, PR, the HER2 enriched increases from all three positive to cases in which HER2 and ER are positive and PR is negative to 57%, and further increases in cases which are positive for HER2 and PR but negative for ER. So among the different subtypes, the HER2 enriched is characterized by the highest expression of HER2 EGFR proteins and the phosphorylated HER2 EGFR proteins. Thus, these tumors are likely to have the highest activation of HER2 pathway and consequently be most sensitive to HER2 targeted therapies. The HER2 enriched subtype is associated with higher PCR rates beyond HR status. As we can see, the response rate of pathological complete response is higher in the HER2 enriched subtype, which is in pink, compared to the non-HER2 enriched subtype. The same trial showed that the subtype distribution significantly differed by HR status. As we can see on the left, the hormone receptor positive cases had higher percentage of luminals versus hormone receptor negative, which had HER2 enriched subtype and no luminals. The luminal A tumor with the lowest PCR rate of 14% carried the best RFS outcome, which is in blue, and the HER2 enriched patients with the highest PCR rate of 61%, which is in pink, carried a significantly worse RFS outcome. The same is shown in the overall survival. The greens are the luminals and the orange is the HER2 enriched subtype. Next, coming to the heterogeneity of the ERB2 gene expression levels. The ERB2 gene expression level is lower in the luminal HER2 positive breast cancers. As we can see in the figure on the right, the ERB2 low has higher percentage of luminals as compared to tumors which are ERB2 high. So the tumors which are molecularly addicted to HER2, that is, they are both HER2 enriched and with high ERB2 mRNA levels, are most frequent in HER2 positive, hormone receptor negative breast tumors. In HR positive, these tumors are just 31%, whereas they increase to 68% in HR negative arm. So these tumors which are both HER2 enriched and ERB2 high identifies HER2 tumors with high responsiveness to HER2 targeted therapy in the absence of chemotherapy. The Catherine trial, there was a significantly worse association of high ERB2 mRNA with trastuzumab. As we can see, the upper blue arms are the TDM1 arms and the with low HER2 and high HER2, and the low ones are with trastuzumab. The hazard ratio in trastuzumab was 2 versus TDM1, which was 1. Good prognosis of ERB2 low with adjuvant trastuzumab can be explained by higher percentage of luminal tumors in ERB2 low cases. Next, I come to intratumoral heterogeneity of HER2. Now, HER2 positive in clinical scenarios is not a uniform disease. There may be some clones of cells which are HER2 negative. So we researched biopsies before the start of the neoadjuvant therapy, and we found that 10% tumors were heterogeneous. Out of these, predominantly 81% were HR positive and 19% were HR negative. The pathological response according to HER2 heterogeneity and HR status is nicely depicted here. In non-heterogeneous cases, as we can see, the PCR is way higher than in the heterogeneous cases. And same in HR negative cases, the PCR is way higher than the HR positive cases. The last heading is properties of HR positive, HER2 positive tumor microenvironment. As we can see in these figures, the immune signature of IgG, CD4, and CD8 is all higher in the HR negative arm compared to the HR positive arm. And in the HER2 enriched type, the IgG, CD4, and CD8 signatures are all higher than the other subtypes. So to conclude my talk, there is a complex molecular signaling crosstalk between the ARPR and HER2 pathways, which may contribute to treatment resistance. In CalGB 40601 trial, PCR is a good surrogate of RFS only in the HR negative tumors. HER2 positive luminal A tumors have good survival outcomes in early stage disease, despite having the lowest PCR rate, with 20% of HR positive, HER2 positive tumors being luminal A. And these cases may be considered for de-escalation of therapy. Intratumoral HER2 heterogeneity is the most frequent in hormone receptor HR2 positive disease, and these constitute almost 10% of cases and is associated with lower PCR rates. And finally, the HR positive, HER2 positive tumors tend to be less immune infiltrated than HR negative and HER2 positive tumors. Thank you for your patient listening.
Thank you, Dr. Bhavna. Indeed, a landmark study, and I'm sure one of these is going to turn out useful in future for outcomes to be predicted. We'll move on to the next speaker, that is Dr. Pankaj Baweja. Dr. Pankaj is a senior consultant histopathology at Indraprastha Apollo Hospital, Delhi. He will be speaking to us on CRISPR screens to identify novel DNA repair defects, synthetic lethal therapies. It was mentioned in brief by Dr. Moshmi, but he will elaborate on the topic right now. Over to Dr. Pankaj.
Good evening, everyone. First of all, I would like to thank the organizers for giving me this opportunity. Ma'am, can you see my screen?
Yes, we can see your screen.
So coming directly to the topic, CRISPR screens to identify novel DNA repair defects by synthetic lethal therapies, which is the original work done by Mr. Daniel DeRocher from Toronto, Canada. Synthetic lethality is a lethal phenomena in which occurrence of a single genetic event is tolerable for cell survival, whereas the co-occurrence of multiple genetic events results in cell death. The 5 most common synthetic lethal screening approaches include yeast screens, drug screens, RNA interference screens, bioinformatics screens, and CRISPR screen. CRISPR means clustered, regularly interspaced, short palindromic repeats. CRISPR is a compelling technology used to investigate various biological processes such as synergistic and synthetic lethal interactions. It is a scalable genome editing technology that is highly efficient and specific, which surpasses RNA interface-based reagents and can be used in high throughput screens by utilization of multiple related approaches to discover novel drug targets. CRISPR-Cas9 system usage in human cells is based on the genome editing technology development that pairs sequence-specific genetic RNAs with bacterial Cas9 expression, whereby the enzyme was guided to excise specific DNA fragments of the human genome. As seen in this figure, when gene A is mutated, the cell is still viable. But by using synthetic lethality, we mutate the gene B and induce synthetic lethality. And this concept of synthetic lethality is exploited by PARP inhibitors. Coming to the background, amplification of the gene encoding cyclin E, which is CCNE1, is an oncogenic driver in several malignancies and is associated with chemo-resistant and poor prognosis. To uncover therapeutic targets for CCNE1 amplified tumors, genome-scale CRISPR-Cas9 based synthetic lethality screens in cellular models of CCNE1 amplifications were studied. Increasing CCNE dosage endangers a vulnerability to the inhibition of the PKMYT1 kinase, a negative regulator of CDK1. RP6306, an orally bioavailable and selective inhibitor, shows single-agent activity and durable tumor regressions when combined with gemcitabine in models of CCNE1 amplification. Cyclin gene amplification has been studied in many tumors. The top 10 tumors have been highlighted here. In this, the topmost is uterine carcinosarcoma, 40%, followed by various tumors. As you can see in this figure, in normal cells, CCNE1 combines with cyclin E and CDK2 and enters at G1 S phase level. However, in CCNE amplified cells, this combo has unscheduled S phase entry, leading to a longer S phase as compared to the normal cells, further leading to DNA replication stress, genome instability, whole genome doubling. And this PKMYT1 is a membrane-associated serine threonine protein kinase which phosphorylates CDK1 to keep it inactive. So development of RP6306, a first-in-class PKMYT1 inhibitor, has been studied with the potency and ADME properties as described in this picture. So mechanism underlying synthetic lethality is there is a hypothesis that there is a critical dependency for PKMYT1 to hold cyclin B and CDK1 in check until DNA replication is completed to avoid catastrophic DNA damage. And this concept has been used by RPC6306, which inhibits PKMYT1, and there is a prediction that it will lead to premature CDK1 activity, unscheduled mitotic entry, DNA damage, chromosome pulverization. So coming to the conclusion, we can use CRISPR-based synthetic lethal screens to discover new drug targets. PKMYT1 is synthetic lethal with CCNE1 amplification. RP6306 is a selective, orally bioavailable, first-in-class PKMYT1 inhibitor, and RP6306 has now entered phase 1 clinical trial. Thank you.
Thank you, Dr. Pankaj, for giving us a complete insight into new therapies which can be used probably in the future to do some therapeutic analysis. We move on now to the last speaker, and the last speaker is Dr. Naveen Agarwal. He is the head and senior consultant of pathology at Action Cancer Hospital, Delhi, and he will be speaking to us on monitoring advanced breast cancer with liquid biopsies.
Good evening, everyone. First of all, I would like to thank organizer of this meeting, as well as team from Rajiv Gandhi, especially Dr. Anurag Mehta sir, as well as Dr. Gurudar sir for giving me this opportunity. And also I would like to thank my colleague who have taken seminar before to make this topic a little easier to understand. So my topic is monitoring of advanced breast cancer with liquid biopsies. So can we demonstrate clinical utility? So liquid biopsy is a concept currently mainly used in in a research setting. Its role in GI cancers has been in adjuvant setting has been demonstrated. However, in breast cancer, it is not. It is mainly in trial basis. So what is basically we want is like a patient of advanced breast cancer always have a systematic relapse, and if there are technologies who can predict the relapse earlier, it can give us lead time where we can plan therapy and convert an incurable disease to curable one. The concept of minimal residual disease is evolving in solid tumors. Here in this plot you can see it's circulating tumor DNA in 4 disease status. Yellow is refractive disease, red is early relapse, and blue is secondary relapse. And you can see there is a lead time between detection limit of DNA and clinical relapse which is detected by radiology. And whether this lead time can be of critical utility is where are really studied in ongoing trials. First attempt with rescue therapy is done in CTRAC trial in early stage triple negative breast cancer. They have done ctDNA surveillance with a 2-armed observation as well as intervention by imaging and pembrolizumab. In the patients who are found to be having metastasis by imaging, they found that 70% of these patients also have ctDNA positive. However, the lead time detected between the ctDNA and radiology is very less, so it was too late for any kind of rescue therapy. Other trials on advanced breast cancer include phase 2 trial by Preserve with the escalated adjuvant therapy with capecitabine and Artemis. Then we have phase 3 trial on triple negative breast cancer doing late rescue therapy, and by Aspira it's phase 2 trial. Then we have early stage of start of first line therapy by DARE and TRACK ER. But the question is delaying the metastatic relapse enough? Trials have demonstrated usefulness of ctDNA in monitoring patients with overt advanced breast cancer, as well as the prognostic assessment in detection of primary and secondary resistance. Liquid biopsies have shown to have prognostic impact prior to therapy also. ctDNA and CTCs have been studied, but their levels are poorly correlated with each other. However, they are found to have independent prognostic impact in these patients versus all clinical pathological characteristics. and each other. If in this plot you can see, red is showing when both ctDNA as well as CTCs are high, as compared to blue, which when they are not detected, the level of survival impact on survival is significant, and there is a log linear impact on HR. Other trials which have shown patient prognosis prior to therapy is CTC trial, where they have seen in ER positive, HER2 negative advanced breast cancer from endocrine therapy to escalation to chemotherapy when CTCs are high, and they have shown in this randomized trial that PFS is more in this arm as compared to PFS when they have done a de-escalation from chemo to endocrine therapy. Also longer overall survival with chemo. However, in the de-escalation arm, the overall survival was not shorter as were done with endocrine therapy. Other trial are AMBER trial, which is also first-line phase 3 trial, which studies ER positive, HER2 negative breast cancer with visceral metastasis and high disease burden. In detection of primary resistance to the treatment, lack of early decrease is known as primary resistance, and there were trials based upon circulating tumor DNA and CTCs. CTCs trials were not shown gain in survival. There are 2 trials here. And then ctDNA, you have a monitoring trial where they have just seen that allelic frequency decrease of 40% as well as increase in 40% has taken as a progression or decrease. So they have switched from first line to second line, then third line and fourth line. The results of this trial is to be known. Then there is a future SAFET3 trial where fulvestrant with palbociclib as a first line endocrine therapy is switch over if there is no decrease in PIK3 mutation at 1 month to fulvestrant with alpelisib. Now, detection of secondary resistance to treatment. There is a PADA-1 trial where in the first line metastatic breast cancer, hormone receptor positive and HER2 negative, which is sensitive to aromatase inhibitor. They have treated with aromatase inhibitor with palbociclib, and they have checked the estrogen receptor mutation at inclusion 1 month and 2 months, and if there is a rising mutation and no progression disease, they have put 2 arms. One is again palbociclib, and the other is switch over to fulvestrant, and they have found that there is a more progression, better response in this arm. And other trials like Serena 6 with camizestrant is also carried out with ongoing trial. So to conclude, liquid biopsies helps in disease monitoring, and it opens up new windows of opportunities, and it really helps when the metastases are asymptomatic, as I have discussed, in escalating the adjuvant therapy, in late rescue therapy, in earlier first line therapy, and its role in prognosis assessment, especially in harmonizing treatment decisions like detection of genes in a liquid biopsy can help you to detect and give best line treatment earlier, as well as in response monitoring, especially in targeting primary resistance as well as secondary resistance, and replacing and de-escalating imaging, especially if we can predict like the patient has low evidence of disease recurrence, then ongoing radiological surveillance can be decreased. However, randomized clinical RCTs are the key, and new strategies can be discussed versus standard care. Crossover studies should be implemented wherever feasible. However, last point is acceptance is an issue in these trials, as because patients' mindset, when they are thinking to have disease relapse, it's very difficult to deal with. And with all this, I would like to thank you for patient kind attention.
Thank you, Dr. Naveen, for sticking to time. And my apologies. We have one more speaker, Dr. Hema Malini Iyer. Dr. Hema Malini is a senior consultant, laboratory medicine, and clinical leader, anatomic pathology at the Dharamshila Narayan Super Speciality Hospital at Delhi. And she will be conducting the panel discussion, which is again on genomic markers and its application. We've been running short of time, so I'm sorry. I will quickly like to invite the speakers of the panel discussion. And the speakers, most of them have already been introduced. Dr. Sudha Murthy, Dr. Anila Sharma is the senior consultant histopathology at the Rajiv Gandhi Cancer Institute, Delhi. Dr. Naveen is just spoken and alluded to certain topics, and so also Dr. Vinita. So over to Dr. Hema Malini Iyer to moderate the session and the panel discussion.
Hello, everybody. Good evening, Dr. Gurudat. Good evening, Dr. Anurag sir. Thanks for having me here. And what a conundrum. I mean, I had a headache trying to sort it out. I'm fine. Thanks, Dr. Anila. Well, can I have the next slide, please? Yeah. We'll be discussing each of the topics just presented. So, I mean, I'll try and be as brief as possible. I know we've exceeded our time. And without wasting any more time, the first topic that we'll be addressing is molecular heterogeneity in HER2-positive breast cancer. Can outcomes be predicted? Next. Dr. Sudha, can you comment on this? Is HER2-positive breast cancer a single disease, or does it represent a biologic continuum?
Yeah, thank you, Dr. Malini, for having me as your panelist. As we have just heard, HER2 positive breast cancer is no more a single disease. Just doing a HER2 would not help to ascertain whether there will be response to HER2 targeted therapy. It's a biologic continuum, and it is dependent on several variables, some of them being hormone receptor sensitivity, the high TILs, the immune, the tumor microenvironment, and other genetic alterations. In short.
Yeah, absolutely. Next. Yeah, so so we highlight those points where nearly 50% of all HER2-positive breast cancer are actually molecularly HER2 enriched, and the two may not be synonymous. Most relevant mutations are found in ERB2. Yes, we just discussed that. So, and of course, as Ma'am just said, tumor-infiltrating lymphocytes, the tumor microenvironment, and will play a major role in determining response to therapy. And just HER2 positivity itself may not be enough. Next. So the biological complexity, this is just a slide which highlights that. And within the HER2 positive group, next slide, there is a 12-fold difference in ERB2 mRNA levels in the HER2 positive category itself, which serves to highlight that there is a dynamism in HER2 positive breast cancer, which probably has not been addressed hitherto. Next slide. Next, please. So why do ERB2 tumors respond more to HER2 therapy? Because they are more HER2 enriched. We've just heard everybody on that. And the HER2 enriched category is usually, as we've just heard again, hormone receptor negative, and they tend to have high ERB2 levels, low TILs. And next slide, please. So this is a HER2-DX is a multivariable prognostic score, an algorithmic score that takes into consideration and integrates clinical genomic variables as well as variables such as tumor-infiltrating lymphocytes. And it presents as a continuous variable and is associated with overall and disease-free survival. But the HER2-DX assay was not found to correlate very well with pathologic complete remission. Next slide. Next. on the previous. Any last thoughts, Dr. Sudha?
Please, Rajesh.
Yeah. Last thoughts. I think we will have more research coming up in this area. This is what is the most loved topic in breast cancer. So, as you had alluded to, the HER2 positive group, there is a lot of difference between the HER2, even in that subcategory, and we see that now ADCs are becoming the standard of care in HER2 low group subgroups. So I'm sure there'll be a lot more interactions that would be studied, and we will have more to learn in this area.
Yeah. Next. The final take-home message, so which we've just elaborated, that within the HER2 positive disease, there is marked heterogeneity, and it's characterized by high B2 levels, the HER2 enriched molecular subtype, and mutations in the PIK3CA, and is usually HR negative with high TILs and immune markers. Biomarkers of PCR do not always predict survival outcome. You've just seen that. Biomarkers of survival outcome are difficult to identify, but a combination of biological variables is needed to predict outcome and also to determine therapy, because if the HER2 DX assay score is low, we probably need no additional therapy, whereas if it is high, we need to add on TDM or an antibody drug conjugate, which combines trastuzumab and emtansine. Next slide. So we'll be going on to the next topic, which is single cell analysis of circulating tumor cells. We've already heard the talk. So I think it makes life easier. Dr. Anila, can you please comment on CTCs and their role in breast cancer?
Dr. Anila, the question is addressed to you.
Hello, Dr. Anila, are you there?
Sorry, I'm here. Can you hear me now?
Yes, we can.
Yes.
Okay, thank you so much. I think everybody is very well versed with the CTC, and we had multiple talks relating to CTC. I'll just stick to the second question, which is role in routine clinical practice. As we know that this CTC has come up in a big way, and it has a role in routine clinical practice in the form of prognostication, detection of primary resistance to treatment. For example, lack of early disease during a new line of therapy. Detection of secondary resistance to treatment, as I think I was read somewhere or in one of the talks, there was PADA1 and Serena-6 trial. The disease monitoring opens up multiple windows of opportunities, especially when the patient's metastasis is still asymptomatic and the adjuvant therapy has to be escalated, or there is we have to change the first line of therapy, etc. And in prognostic assessment and harmonizing the treatment decisions. So I think you will be elaborating more on the CTC.
And next slide. Yeah, this is just, we've seen this before. So this is just to demonstrate the circulating tumor cells and highlight the fact that only 1 in a billion red blood cells is actually a circulating tumor cell. So we are looking for a proverbial needle in the not even a haystack, actually a needle in the sea. And eventually these CTCs will produce metastasis. So the idea of picking them up early to metastasis and next slide. Yeah, this is just what the CTC and its protein applications, which are very many, including a lot of in vivo tests, as well as monitoring of RNA, DNA, genomic signatures, and proteomic signatures. Next slide. Yeah, cellular plasticity, we've already discussed that in some detail, and which contributes to tumor heterogeneity and diversity, and also confers metastatic potential. Especially the epithelial mesenchymal transitions. The epithelial mesenchymal transitions result in the epithelial cells acquire mesenchymal phenotype, which facilitates distant metastases. There are several other variants, including mutations in cell cycle. So cells can be in the proliferative phase or quiescent phase, can be HER2 positive, negative. So and all these together contribute to heterogeneity. Next slide. Next, please. Yeah, so in CTC-based screening, basically the epithelial CTCs tend to be more proliferative, whereas mesenchymal, vis-a-vis mesenchymal CTCs, and they exhibit increased ESR1, HER2, and AR expression. Next slide. High, that is ribosomal protein CTCs, are epithelial and more proliferative, and the presence of high RP confers the prognosis on tumor. And mesenchymal breast also express differential mTOR. So the detection of plasticity and the ability of cell to change its identity is important because it causes a lot of phenotypic changes which determine therapy. Next slide. Next, please. Yeah. So there's a differential, as I said, mTOR activity in epithelial and mesenchymal tumor cells in the primary tumor as well as in the CTCs. This slide demonstrates that. Next slide. So the ribosomal protein L15 overexpression increases metastases, and this is another important attribute of epithelial cells, that is the epithelial phenotype of the CTCs. Next slide. So is there any role, Dr. Anila, at present for mTOR inhibitors in breast cancer?
Dr. Anila.
Hello. Yeah. Am I audible? Yeah. So there are multiple trials going on, and already there are. I think in the last SABCS also there were few presentations on the PIK3 mTOR inhibitors by Dr. Badia and etc. But I wouldn't be very wise to go in details about it.
I think subsequently everolimus has now been approved for HR positive and HER2 negative breast cancers, which is an mTOR inhibitor. And since the approvals have come through, probably will soon be in use in HR positive and HER2 negative subset of breast cancers. Next slide. Next, please. Yeah, so the final take-home message, epithelial mesenchymal transitions, which means the acquisition of mesenchymal features, increases invasiveness and metastases, and patients without detectable transitions in the peripheral blood have longer disease-free survival, which is not surprising. Overexpression of ribosomal protein L15, and which is a component of the large ribosomal subunit, also enhances metastatic potential. And in vivo genome-wide CRISPR and CTC screening identifies enrichment of targets involved in protein translation. And there is a role, as we've just discussed, for mTOR and the phosphatidyl inositol 3K inhibitors in breast cancer. Next slide. We next move on to the next topic, which is novel epigenomic targets in TNBC. We've already gone through that. Dr. Naveen, can you please just a brief on epigenome and its role in cancers?
Hi, good evening, everyone. Epigenome, just briefly, I want to tell, for each cell has got a unique DNA sequences, which is controlled by primary epigenome, which is regulating the differentiation. So what happens is how it's regulated. These sequences are basically methylated, and rest of the DNA sequences are non-methylated. So what happens in these regulate the differentiation into cell type. And in cancer cells, what happens is there is a hypermethylation of this promoter region, as well as hypomethylation of a whole genome. So this what actually does it changes the differentiation of the cell. So in a nutshell, I can say, like, if you see a software and hardware of the computer, hardware is the DNA and software is basically the epigenome. So they are making switch on and off. So in this tumor, there are a lot of treatment based upon epigenome, because especially in triple negative breast cancers, because they are not they are very notorious to they are mutating, they are resistant to treatment. So what happens is, like, we can target this epigenome treatment with chemotherapy and endocrine therapies, and we can have a multiple targets, cellular targets, which can really helps to a better response. There are a lot of ongoing trials based upon it, and the role of epigenomes are mainly in triple negative breast cancers have come out well, especially, like, I can say in also in other cancers also. Yeah.
Thank you, Dr. Naveen. Thanks so much. Next slide, please. So triple negative breast cancer, as Dr. Naveen just said, the conventional therapy that is currently in use include chemotherapy, PARP inhibitors, PD-L1, immune checkpoint inhibitors, and the TROP2 ADC, that is conjugate, and basically using targeted therapy against the trophoblast cell surface antigen. Next slide. I'm not dwelling on this because this is a slide that has already been shown by a previous speaker. Next. Yeah, so there is a growing menu of epi-drugs. We've seen that. And among the epigenomic targets, the most important are these bromodromine extra-terminal proteins, and these extra-terminal or BET proteins, as they are known. And a lot of these inhibitors that are being developed against these BET inhibitors, as well as against the protein arginine methyltransferases. We've already been through that. And the PRMT inhibitors and PRMTI other inhibitors, because there are large number of protein arginine methyltransferases. Next slide. So this is the PRMT5 inhibitor, which has already been explained by, I think, Dr. Vanitha. So which has been shown to have activity in breast cancer cell lines. This is still at the preclinical stage, in the in vitro stage. Next slide. Yeah, so there are future opportunities, as I said, and needs randomized clinical trials and testing to determine whether or not they prove to be fruitful in the clinical setting. Next slide. So epigenetic therapies are usually used in combination with other chemotherapy or targeted therapy, and these could include epidrug combinations with PARP inhibitors. This is basically for hormone receptor positive and proficient cancers. Next slide. Dr. Naveen, is there any role for BET inhibitors in conjunction with other targeted therapies?
Yeah, first of all, we should know what is BET mechanism. Cancer cells are basically have a survival gene, MYC and BCL2. So BET basically helps to, give enhance these survival genes like MYC and BCL2. So when we give BET inhibitors, these survival enhancers are lost. So cancer cells are prone to therapy. So when we do a combination therapy like BET inhibitors, so we are giving a two-prong approach. Once we are with BET inhibitors, we are destabilizing the cancer cell, and if we can add PARP inhibitors with that, which acts on a DNA synthesis, it's going to be really changing. So these are the therapies which are being currently on trial basis. They have been seen, and I think this is best of my knowledge. These clinical colleagues can elaborate much better about this. Thank you.
Absolutely. Next, please. Yeah, so BET inhibitors, as Dr. Naveen just said, exhibit synergy with olaparib, which is a PARP inhibitor, and have been shown to, there are trials on which are showing that this is indeed true, and that BET inhibitors do enhance the effect of PARP inhibitors. Next slide. So the evaluation of talazoparib with Zen 3694 in non-BRCA triple negative breast cancer. This is basically a combination again of PARP inhibitor and a BET inhibitor. Next slide. Epigenetic therapy can also be tried in those cases which exhibit drug resistance. And so there is induced vulnerability to the EZH2 inhibitor. Epigenetic therapies can also be used in combination with immunotherapy, that is immune checkpoint inhibitors. Next slide. For example, entinostat with atezolizumab. And atezolizumab, as we all know, is a PD-L1 inhibitor that is currently used in triple negative breast cancer, especially in conjunction with SP142. And you can add on entinostat to that, and which is an epidrug. And in combination, the two are shown to have synergistic effect. Next slide. Any last thoughts, Dr. Naveen?
Yeah, I think we are going to see a new world of treatment in TNBC, especially with this scenarios like evolution of CTCs and epigenetic drugs. Treatment is going to be little after a decade. I think it's going to be little very, very good, and prognosis will be much better. Thank you.
Yeah, absolutely. So we need to wait and watch and see how the scene develops. Next slide. Summary. Just to sum up, TNBC is a challenging disease. We all know that. And the most important challenge that is faced in the treatment of TNBC is the development of drug resistance. And the drug resistance could be either primary or secondary. So epidrug combinations, although the only thing that probably limits the use of epidrug combinations is toxicity. And so we need to carefully assess tolerability. And these require randomized clinical trials in order to assess the relative dose-benefit ratios. Next slide. So then we come to the last topic, which is genomic biomarkers, novel approaches and targets. Dr. Vinita, can you please comment on genomic markers, the current state?
Thank you, Dr. Hema, for including me in this, discussion. Now, as I understand it in this entire presentation, what I've understood is that there is what is the biology of the tumor, and there is the evolution of the tumor. So both of these are determined by the genomic, the epigenomic, the tumor microenvironment, and the immune response. So these are the four main pillars on which the biology of the tumor and the evolution of the tumor proceeds. Now, it is very heartening to see the advances in detecting these various, I'll try to just elaborate. For example, for the biology of the tumor, you have genomic targets like the ESR mutation, epigenomic targets, which we've already discussed, the BET inhibitors, and tumor microenvironment, the neurotransmitters were mentioned, and immunity, we already talk about it in PD-L1. Now, in the evolution of tumor, when you have all these, the point is to make it as less painful for the patient as possible. And then you have these really novel techniques of circulating tumor DNA, which can alleviate so much of pain, patient going through the expense and pain of a biopsy. And you use these techniques to see how the tumor is evolving. And in that, we try to look for drug resistance, as we've already noted down. Different pathways are there to drug resistance, again, genomic, epigenomic. And those are, it's a challenge to look for those. So then we decide whether, the patient is going to get more adjuvant treatment or, let's say, a high intensity treatment, and she'll be prone to metastasis. Or on the other hand, you identify patients who don't need chemotherapy. For example, your HER2 positive enriched patients who respond very well to trastuzumab, and they don't need additional chemotherapy. You can prevent them from going through the toxicity. So it's a very challenging and a very dynamic science at present. And at the end, I would like to just talk about, then there are these tumor agonistic biomarkers, which can be applied to almost all tumors. Like you try to you manipulate synthetic lethality, you try to, picture those the PARP inhibitors are better for germline mutated BRCA patients, but we are trying to find out how we can broaden the patient base who can benefit from PARP inhibitors by, attacking the homologous recombinant pathway. Then you have PIK3 mTOR pathway inhibitors, how they can be used. The NTRK pathway can also be utilized. You have pan treatment for those. And not to forget the, antibody drug conjugate, the drug sacituzumab, which can be used. And so it's really challenging to see how the basic principles of cancer biology are being, I would say, manipulated to try to overcome this very, very challenging disease, and it's heartening for the patients.
Dr. Hema? Dr. Hema? Well, while she comes back on screen, I'd like to say that there are no questions. There's a comment from Dr. Sudha saying that CTC-based screening easy check for breast cancer and prostate cancer very recently from Data Cancer Genetics has received US FDA breakthrough designation. Sorry, Dr. Hema, that was a comment from Dr. Sudha, so I just interrupted while you came back on screen.
This is basically, we've just gone through this, genomic biomarkers. It's a field that is burgeoning now. We have far more therapeutic than we had before, and a large number of actionable targetable mutations and a large number of therapies that are currently available. We've all discussed the various ctDNA sequencing modalities, including shallow whole genome sequencing and targeted sequencing, as well as the ddPCR and so on, and whole exome and whole genome sequencing. And I will not dwell on it because there is, I think we are running short of time. Shallow
whole genome sequencing.
Yeah, so shallow whole genome sequencing has been discussed, which is a rapid high throughput technology that picks up, that sequences the whole genome in conjunction with bioinformatics. Next slide, please. Next. So in addition, something that we I think have discussed before, BCL6 amplification and its association with CDK4/6 inhibitor resistance. So the development of cyclin-dependent kinases, inhibitors, resistance to these inhibitors like and amilvaciclib is associated with BCL6 amplification. So the addition of anti-BC therapy could help. Next slide.
Ma'am, could you kindly wind up?
The DNA matrix could. Yeah.
Move fast.
So DNA matrix predicted. Next. So in summary, circulating
Well, I think we'll stop now. And as I said, there are no more questions. With that, we come to the end of this session. And before we wind up, can I request all my speakers to put on their videos so that we can take a photograph together? Can I request all the others also to come on board? Dr. Hema?
Thank you, ma'am, for the session, and Dr. Hema and Dr. Guru that also.
Thank you so much. And lastly, I'd like to thank my erstwhile head of department, Colonel Anurag Mehta, and Dr. Gurudat for inviting me for chairing this session. And I'm sorry for the delays, but I can blame them partly on the technical glitches.
Thank you so much, ma'am.
Thank you, ma'am.
Thank you. Thank you, Dr.
Thank you, ma'am, for chairing the session. Now I are coming to the last. We are coming to the last two presentations. One is by me. I'll be talking on the innovations in pathology. So let me share the screen. Is my screen visible?
Yes, it's visible. Full screen. Slideshow.
Yeah. So this was the spotlight poster presentation, Innovations in Pathology, which included 4 pathology posters. So I'll just, yeah, going too fast. Now, we all know the digital pathology is an environment or digital imaging, and it starts with whole slide imaging. With the advent of rapid scanners and the decrease in storage costs, it has been adopted across the world. Now, primary digital diagnosis, it started in earnest in 2017 when the FDA approval was granted to Philips ultra-fast IntelliSight scanner. And this led to increased clinical adoption in US, and it was further accelerated by the pandemic because it permits remote viewing and diagnosis of the digital images. Now we come to a very important topic, computational pathology. Now, computational pathology is defined by Digital Pathology Association as omics or big data approach to pathology. Now, in this, multiple sources of patient information are including the pathology image data, and metadata are combined to extract the patterns and analyze them. Now, the Page Prostate was the first FDA-approved AI product for digital pathology. This Page Prostate is a New York-based AI company startup, and it was started by Dr. Thomas Fuchs, and in 2017, and you'll be surprised to know it received $220 million of funding. And this was the first system, which was a landmark, which received FDA approval. So what are the opportunities of this computational pathology? Now, first is it improves diagnostic accuracy, the efficiency of the pathologist. We can say that for Page Prostate, where they showed that the diagnostic accuracy for the slides, which was screened by the pathologist in first read, the second read, and then the assisted read with the AI product, led to improvement of 7.3%. And it also leads to increased efficiency because it highlights the suspected areas. For example, if it is a very small area, it will be picked up by the AI system. So this is the advantage of computational pathology. Now coming to the resource limited settings. Now in resource limited settings, like where you don't have the subspecialty practice or the specialist pathologist, you can use the AI system to assist the pathologist in making a correct diagnosis. And it helps in develop better diagnostic and prognostic criteria with objective and quantitative measures. So that is, we can say for, say, prostate biopsies, where the accurate Gleason scoring, the quantification can be done. Now, what are the challenges? The biggest challenge, as we will see in subsequent posters, that the volume of data, the slides which are required, is enormous. And second issue is the quality of the data. The data has to be curated, it has to be properly annotated, and it has to be accurate. If you have a faulty data, it will give rise to a poorly trained AI. Now coming to computational and digital infrastructure challenges. Now computational challenges are that you require a very good hardware to run this softwares and generate proper results. Now, digital infrastructure, as you know, the bandwidth and other problems come. Now, the first poster is subtyping invasive carcinomas and high-risk lesion for machine learning-based breast pathology. Now, this was presented by Matthew G. Hanna in collaboration with Page AI. And the first two posters are both from Memorial Sloan Kettering and Page. Now, what they have shown is this, that they use Page Breast Beta. This is a software, AI software, and they use it to classify pre-neoplastic and neoplastic diagnostic category, just like we have seen with the Gaurav's poster using IBEX AI system. Now, they also classify the histological subtypes like apocrine, mucinous, and others. So you can see the amount of data they have used. For training, they use 40,000 slides, and for validation, 11,400 slides. So this is a massive amount of data which they could source from Memorial Sloan Kettering. And they trained using slide level labels. Now, what are slide level labels? Now, this slide level labels are the ground truth which is given to one particular whole slide image. So you say that this slide is, say, invasive breast carcinoma, and whichever type it is. So that becomes the slide level label. Second approach is to give patch level labels that we'll see in last poster. So subtyping of invasive breast carcinoma, they have shown that, like for solid papillary, it was area under curve was 0.90, and for mucinous it was 0.99. So it was excellent, and for pre-neoplastic also it was quite good. And you can see the page, it marks the area of interest, in this case, malignant duct, by heat map. So to conclude, they said that trained CNN has high performance in identifying the presence of ADH, ALH, DCIS, IDC, ILC, LCIS, and the subtyping apocrine, micropapillary, mucinous, solid papillary, and tubular carcinoma. So they have expressed this hope that this can be used to detect microinvasions and calcification in breast tissue using the same approach. Now, the second abstract, the poster is also from the Memorial Sloan Kettering. This was presented by George S. Rees Fellow, and this is based on an artificial intelligence-based predictor of CDH1 biallelic mutation and invasive lobular carcinoma. So aim of this study was to basically identify the invasive lobular carcinoma and biallelic CDH1 inactivation. Why invasive lobular carcinoma? Because the diagnosis of invasive breast lobular carcinoma is sometimes difficult, and it has a lot of inter-observer variability. And they said that molecular surrogate, that is biallelic CDH1 inactivation, is highly specific for invasive lobular carcinoma. That is more than 95% will have some changes in CDH1. So what they did was they curated 1,100 primary breast cancers, which had been subjected to genomic analysis at Memorial Sloan Kettering, and they gave it a ground truth that they should have somatic mutations or mutations plus LOH. Now, these were used for training. So this was their data. CDH1 was there in 143, it was biallelic, and 957 were wild type. Lobular subtypes histologically were 173 and 927 were non-lobular. So they evaluated the revised ground truth, and that further reclassified some labels. So this is invasive primary cancer sample. In that they apply the previous software, what we have seen breast beta, that was trained on 40,000 whole slide images. Then it was used to identify the salient tissue. And on this, they applied the CDH1 biallelic mutation classifier system. Now, this further gave the two classifiers, CDH1 biallelic mutation and no CDH1 mutation. So what they said was that if you use this, the training set as a curated data using the ground truth of CDH1 mutation, you get better sensitivity and accuracy than using the histological label that is which is used for lobular carcinoma classification. So that they concluded by training a machine learning to detect CDH1 biallelic mutation as ground truth rather than histologic diagnosis of lobular carcinoma, which might be confounded by human subjectivity. They developed an AI-based system that can detect ILCs accurately, provide new paradigm for use of orthogonal ground truth. So that was their conclusion. However, we should understand this, all this is research setting, and these are not in diagnostic use. Now coming to the last poster. Now this was on deep learning applied on resection specimen. The tissues slides of pure ductal carcinoma in situ predicts ipsilateral invasive breast cancer recurrence. Now this was presented by Dr. Shannon Doyle. She was from Cancer Institute, Netherlands. Now their premise was that ductal carcinoma diagnosis is overtreated, that is by surgery or by radiation. So they try to predict the recurrence of invasive breast carcinoma in the ipsilateral breast by using the training set of 235 H&E slides, which had 10 years follow-up with no radiotherapy and had recurrence in 167 cases. So this was their training set which they used, and the detection use was, as we have already said, a patch approach was used in which the part of slide was annotated and then it was aggregated. So detection of ducts followed by duct level classification and aggregation was used. So this is their data. The RT negative, 249 cases, 125 recurred, 125 no recurrence. And in cases where RT was given, out of 143, only 42 recurred. And WSI was tiled to patches of 1024 into 1024 pixel. So this was use of patches, and slide level approach we have seen with previous two posters. So deep learning was applied, and 10-year IBC recurrence risk was calculated with 5-fold cross-validation. What is 5-fold cross-validation? Say if you have 100 cases for training, what you do is you divide them into 5 equal parts, say 20-20, and then use 40 for training and 20 for validation. And you repeat it 5 times so that your algorithm get good training. So this is one way. However, their numbers is very small compared to the MSK CC cohort. So self-supervised pre-training improved performance for RT negative subjects. So what is the self-supervised pre-training? So in self-supervised training, what is done is the deep learning algorithm is allowed to learn by itself. However, it withheld some part of information by itself, and then the system is encouraged to predict the hidden part. So that is called supervised learning. So they concluded that distinguishing lower and higher subsequent ipsilateral IBC risk was possible by their model, and they have shown that this area under curve was 0.93 when only RT negative subjects were used for training. So it improved from 0.81 to 0.93 when only RT negative subjects were used for training. So correctly distinguishing lower and higher subsequent ipsilateral IBC risk, personalized DCI management for patient, where active surveillance rather than surgical removal of lesion may be possible, potentially identifying biologically relevant features of DCIS progression, and they excluded radiotherapy treated cases as they are likely to reduce prognostic power of model as radiotherapy treatment reduces ipsilateral IBC recurrence. Now to summarize, the use of deep learning algorithms improves lesion detections. DL models can help in risk stratification. The training validation data remains a big challenge because we have already said you require a huge amount of number of slides to actually train a algorithm so it can be accurate. With small amount of slides, the training is incomplete. It will give you errors. And sharing of resources by federated or swarm learning is the way forward. What is federated and swarm learning? In federated learning, what you do is, like I put my all slides into the cloud, and say Apollo puts all in the cloud, and Tata puts in the cloud, and anybody who wants to validate their AI system can use that cloud to validate the AI platform. So that is the idea of federated. Whereas in swarm learning, there are multiple nodes. So you can, using the data at different nodes, you can train your system. So you have to give your codes to all other centers. They will validate independently your AI system. So these are two ways of learning which may be the way forward. Now just about something about future. This Muse microscopy is basically microscopy with ultra violet surface excitation. It is a novel microscopy technique which can actually scan the tissues on the blocks also. So there is no need for scanners, no need for bright field microscope. It generates a 3D image, and it can actually develop a more accurate precision medicine models because it has much more information, the spatial information of with epithelial cells, the stroma, and the inflammatory cells. So it may be the future and may replace the conventional models what we are using now. And it is faster, cheaper, and it can give you better prognostic information. Thank you. Now hello? Yeah, now I invite Dr. Aparna Dhar. She is working in core diagnostic as head of department, medical genetics and genetic counseling. She will be talking about the role of BRCA testing and other markers in breast cancer. Over to you, Dr. Aparna.
Right, good evening, everyone. Thank you, Dr. Dutt, and thank you, organizers, for having me here today. So I've been given quite the task. I'm the last talk of the evening, so I'm going to try and keep this short, crisp, and wrap it up as quick as possible. So we're going to be talking about the molecular landscape of breast cancer, and we know that in 2022, molecular profiling has become the new norm, and it's become very important also because we've understood that we've understood that tumors can have, different profiles that require different therapies. One target could potentially, treat multiple tumor types. So there are agnostic markers. We've learned that one target, one drug will eventually lead to resistance. We've learned that one target, one drug does not always inform you for the other potent targets. And one target, one drug does not always give you the full picture. So when we talk about the molecular landscape of breast cancer, I think understanding tumor biology is very important. We know breast cancer patients are classified as per the ER/PR and HER2 status. The triple negative, which constitutes around 15% of patients, with treatment options of chemotherapy. Then you have your HR positive, which is around 70% of our patients, and hormone therapy is the mainstay of treatment. And then you have 15%, which are your HER2 positive, HER2 positive, where anti-HER2 therapy actually improves significantly the prognostic outcome in both early and advanced settings. But we've actually moved beyond this intrinsic subtype, such as your HER2 positives, your luminal A's, your basal-like subtype, and we're starting to look more into, the genomic drivers, where you've gone beyond your simple classification. We're looking at alterations in the PIK3CA pathway, where looking at DNA repair genes, we're looking at resistance mechanisms in in the ER signaling pathway, and we're looking at growth factor receptors like FGFR1, which could potentially allow us, to have more targets that in turn will allow us to personalize treatment strategies in patients with breast cancer. And this is becoming more and more important in patients with metastatic disease. So the molecular landscape we know is very heterogeneous, and as you can see here, in the slide, is that within each subtype, be it the HR positive, the triple negative, you have a plethora of different somatic mutations that can occur. And if you look at the differences between the early and the metastatic types, you see that there are at least 9 driver mutations. You've got your TP53, your ESR1s, your AKT1, and more frequently, these are more frequently mutated in the ER positive metastatic breast cancer versus the early. And in the metastatic triple negative, it showed an increase in the frequency of somatic biallelic loss of function mutations, and these were genes related in homologous recombination repair. And the metastatic breast cancer patients also showed an increase in the mutational burden and clonal diversity compared to early breast cancer. Now, the poster child for building an a molecular profiling algorithm has always been lung cancer. So I'm going to try and do this with breast cancer. Again, this is a very simplistic view of patients with breast cancer. And this flowchart essentially alludes to the fact that one, you only have 3 biomarkers, ER, PR, and HER2/neu. It assumes that these biomarkers stay static. And we know that when a patient's tumor recurs or when a patient has stage 4 de novo on progression, these biomarkers are not static. And about 30% of patients, ER, PR, HER2/neu, can have a loss or gain of function. In addition, it also assumes that there's only one pathway that is dominant, which again, I'm going to show you that you really need to look at all the different pathways that are activated to help treat your patient. Again, this is a very simplistic view of patients with metastatic breast cancer. Chemotherapy is your treatment of choice. What I want to highlight with this is that with each line of therapy, with each line of treatment, you see a decrease in the PFS. Now, if you look at the tumor biology of the triple-negative breast cancer patients, we know that they are typically associated with the worst prognostic outcome. And as you can see from this heat map over here, that patients with triple-negative breast cancer, it's not as simple as we think it is. Even amongst a group of patients where we have subtypes like the luminal AR, you've got your mesenchymal, you've got your basal immune suppressed, your basal immune activated, and among each of these subtypes, we actually have different treatment strategies, such as immunotherapy for basal immune activated subtype. You've got your PARP inhibitors for those with alterations in the DNA damage repair pathway. You have immunotherapy combinations in your basal immune suppressed subtype. And of course, you've got this anti-androgen therapy in your luminal AR. So it's not a very simplistic view. So what I've done is here, and I think what I personally feel is the optimal molecular diagnostic algorithm for our patients with a triple-negative breast cancer, especially the metastatic type. So if you target the defect in the DNA damage repair pathway, we know we've got PARP and platinum therapy, and they've got very clear roles. And you can actually target the inflamed phenotype where immunotherapy has a clear role. The AR pathway, if positive, we have agents. If you have alterations in the PI3K pathway, we know that we have, what are they called? AKT inhibitors. And last but definitely not least, those agnostic markers like your NTRK fusions. We know RET has an orphan drug status. There's so much data coming out with EGFR T790M being a potential biomarker. It is in the clinical setting, but this is a forever, evolving algorithm. This is not set in stone. But what I'm very quickly going to do is I'm going to walk you through the data that I've used to build this algorithm. So I've used the Impassion 130 trials for TNBC patients, which illustrated in the PDL1 positive cohort and improved in the OS as it's depicted in these Kaplan-Meier curves. Then in the triple-negative breast cancer patients with a germline BRCA mutation, we've got the IMBRCA and the Olympia trials that alluded to the fact that if you have a mutation in the biomarker being the BRCA1 or the BRCA2, and a PARP inhibitor was given, you actually saw a very nice separation in the Kaplan-Meier curves, which were favoring the group of people who received a PARP inhibitor. Now, this was a very interesting data from a phase 2 trial where triple-negative breast cancer patients received a combination of chemotherapy in the form of paclitaxel and capivasertib. Capivasertib is a target for the PI3K pathway. It's an AKT inhibitor. And what you see again is a pretty nice separation in these Kaplan-Meier curves, which are favoring the patients who were getting the combination versus those tumors who did not have an alteration in their pathway. Then we move on to the molecular diagnostic algorithm. This is what is there for your HR positive, HER2 negative. And these patients not only have ER/PR as potential biomarkers, but we also need to look at different pathways, such as those that could acquire an ESR1 mutation, because we know that agents like aromatase inhibitors, do not work very well. And you have to look at agents such as fulvestrant. Again, in the HR positive, there can be defect in the DNA repair pathway where PARP inhibitors can work. We get this from the Olympia trials. And we've also, we can look at the AKT pathway, and then you've got your agnostic markers. So something that's very important and stands out for me in the HR positive cohort is that I think the tumor biology, especially in this cancer type, this disease type, this subtype, is very, very important and should be made the new norm. The reason being is that patients do acquire that endocrine resistance. You can see this is a very nice animation over here. You see patients with resistant, endocrine sensitive, their tumors have a very small clone of the ESR1 mutation. And if you give them, you give them hormonal therapy, and what we see is that around 18% actually acquire the ESR1 mutation, 13% have a defect in the MAP kinase pathway, and about 9% of these have acquired mutations in the MYC pathway. So these acquired genomic alterations eventually does result in endocrine resistance. And some somatic, there is somatic mutations that differ, we know, in the early and the late metastatic breast cancers, especially in our ER positive subtype. And one of the things that's been very interesting in the last couple of years is the identification and development of the tumors that are acquiring what we call an Applebeck signature in high TTV. And these could be potential markers. So this is a very nice study that was, not a study, sorry, it was a case study that was presented at ASCO 2018. And the patient initially had an ER positive breast cancer in 2001, and it was appropriate, was given the appropriate treatment for early breast cancer, and eventually there was a recurrence in 2010. And then you see that, after multiple lines of therapy in 2015, an Applebeck high signature was found. She was eventually treated with immunotherapy in the form of pembro and chemo, and what you can see that she did have a pretty decent response. Now, I just very quickly want to go on to this because we are talking about the HR positive, HER2 negative. We usually start off immediately with the CDK4/6 inhibitor. And, essentially when we start treating our patients with that, we're setting the stage for these tumors to eventually progress on this therapy. And they're developing resistance, which can actually impact the subsequent treatment decisions. So with respect to resistance to CDK4/6 inhibitors, I thought this particular paper very beautifully reviewed that you essentially divided them into two big groups. On one hand, you have your cell cycle with non-specific mechanisms, things that alter your signaling pathway outside the cell's machinery itself. And then you have changes that are happening within the cell cycle machinery. So among those cells, you have these non-specific mechanisms. And something that I want to again highlight in particular is the loss of ER. This is a small subset on that, where you can lose an ER on a CDK4/6 inhibitor resistance. And this is most commonly through changes in the receptor levels with FGFR amplifications or changes in the signaling component that is there within the PI3K kinase pathway, including changes in the PI3K kinase itself, AKT or mTOR signals. So in terms of cell-dependent or specific mechanisms, you would actually expect to see the most common one to be the loss of RB, the retinoblastoma protein. But luckily in breast cancer, we don't tend to see this as often, else it would be really nasty, like what we see in the small cell lung cancer transformations. What we tend to usually see are amplifications in CDK4, CDK6. Now, I have gone on about how, that these targets are not static, and, they are interconnected in a very tight mesh of signaling molecules, and, that sort of, the simplified way of showing it is this triangle. And what it does is it actually emphasizes the three most important angles, the three most important nodes in the signaling network. On one hand, you have your ER, on the other hand, you have your CDK4/6, and then you have up there your PI3K pathway. Whatever you do with the ER positive signaling, if you block one, so let's say that we block the ER over here, if you block the ER, the PI3K and the CDK4/6 act up. And if you block the PI3K on its own, the ER signaling goes up. And this is why actually we never give a PI3 kinase inhibitor as a single agent, because this has a mechanism to adapt to its situation and increase the other components in this, the different angles of this triangle. And what this triangle also very beautifully illustrates is that we're in a new age of clinical trials now. We've had great success in developing various doublets, whether it's endocrine therapy with CDK or hormonal therapy with PI3K or mTOR. It's now a new way where there's a lot of trials that are going on that are looking at actually targeting all three of this simultaneously. So exciting stuff, around the corner. And while we're talking about the PIK3CA, we're very familiar with the SOLO-1 trials. It was a cohort of patients with a PIK3CA mutation who were treated with a combination of fulvestrant and alpelisib, which is a PIK3CA inhibitor, and he saw very good response. What was important over here is that it really didn't matter if this mutation was identified on a liquid or a tissue biopsy. In fact, on the liquid, there was a chance and a high sensitivity of pulling out these particular mutations. So I've said this before, you can acquire a HER2 mutation. And over time, we've seen this more in our patients with HR, hormone receptor positive breast cancer. So this phase 2 summit trial actually, looks at patients with HR positive HER2 mutant breast cancer, and it gave them a combination of neratinib with fulvestrant. And these heavily pretreated, these were again heavily pretreated patients, and the combination did result in a clinical benefit of around 47% and a PFS of around 5.4 months. So here's a slightly more personalized approach. When you're HR positive, when you factor in your aromatase inhibitors, when you CDK4/6 inhibitors. Now, the flavor of the season has always been PARP inhibitor. It's everywhere. So I very quickly want to draw your attention to a very important concept called BRCA reversion. So, and this is especially in our heavily pretreated patients. So BRCA reversion is a phenomenon whereby the BRCA alterations have the potential to restore their reading frames and revert to the wild type sequence, or remove an initial deleterious alteration and restore at least some sort of partial BRCA function. And this is, BRCA2 is more susceptible to this. And this was a very nice case study of a breast cancer patient, HR positive, HER2 negative, heavily pretreated, and they did a germline test, and they did even a tumor profiling. They found a BRCA mutation in her germline. She was treated with PARP inhibitor. She had a PFS of around 8 months. She progressed. They added chemotherapy, but it continued to progress. They did a liquid biopsy, and it showed that there was a BRCA reversion. And we also know that ESMO has actually come out with a scale for the clinical actionability of molecular targets, specifically with breast cancer. And you can see the level 1 to evidence, it tends to be in terms of looking for your HER2 amplifications. You've got your germline BRCA mutations, you've got your PIK3CA, MSI, NTRK, ESR, PTEN loss, AKT mutations. And we also have a plethora of different targets which has less evidence that supports it, but we still look at them because there are a lot of clinical trials that are investigating them. Now, we know that breast cancer, especially metastatic, is heterogeneous, and we do have a problem combating tumor heterogeneity, and especially when you're trying to trace those, biomarkers in your patients. So one way to really look at the genomic landscape is actually through a liquid biopsy. Essentially, what you're doing is you're looking at the circulating tumor DNA, which is somatic or tumor DNA, which is being discarded into the bloodstream, and the ctDNA is isolated and studied. As we heard in our panel discussions, that there is a lot of great work happening around circulating tumor cells, but due to paucity of time, I'm not going to be talking much on it. So with liquid biopsies, they do help with metastatic breast cancer patients, and it actually helps us detect 2 types of resistance mechanism. Now, the first one is where you're looking for, the linear clonal evolution, which basically involves tumor cells, where you have a temporal evolution where one dominant clone, so you lose that dominant clone, and one of the less dominant clones becomes dominant over time, and this gets selected out by therapies. The second one is what we call branch clonal evolution, where you have a spatial evolution in terms of divergence of different clones that happens, and you essentially get a mixture of cancer cells, which is resulting in resistance. So liquid biopsy has various aspects in clinical practice. There's screening, there's recurrence, but for us, I think that's still, it's not ready for clinical practice. So today we're going to focus on the metastatic disease, which can actually help us in tumor profiling, tailoring drug treatment, monitoring treatment response, and most importantly of all, addressing the issue of tumor heterogeneity. And one of the questions that we tend to ask ourselves is that what is the kind of clinical utility? What is the benefit of looking at ctDNA in metastatic disease versus just profiling the primary tumor? So this was one of the objectives in the MIRROR study. It evaluated the concordance of genomic variants between the primary tissue and ctDNA in patients with metastatic breast cancer. And what the authors found was that there was a concordance of around 97.2%, and 13 variants in metastatic tissue, and ctDNA was not present actually in the primary tumor, which again says the tumor biology is important, it's evolving. And the ctDNA could actually be used to detect genomic alterations in patients with these cancers. And obviously, we've got a really, really high rate. So again, another question is that, can we use liquid biopsies to actually detect these driver mutations, for treatment? Can we do it right in the beginning, or do we have to wait for tissue? And this was a lovely case that was presented by Dr. Chandralal Pathi, I think I got his name right, from the Memorial Sloan Kettering group. And this is of an ER positive patient, known case IDC. And they did tumor and ctDNA testing simultaneously. And what you saw, if you just look at the ESR1, I'm not going anywhere else, the tumor was able to call out the ESR1 mutation in July, whereas the liquid was able to call it out as early as February 2015, which was not detectable in the tumor at that point. So again, liquid is very, very good, especially in our HR positive, HER2 negative, and calling out these resistance mutations. So I'd shown you earlier the results of the SOLO-1 trials where patients with PIK3CA mutations were treated with fulvestrant and alpelisib. They had a very good PFS. Then there's a question, what are the other markers that were there within this group of patients that would actually allow you, to tease out who would and who wouldn't really respond to alpelisib? So this was a very interesting paper that came out, I think, in 2020, the year has just started, sorry. And it was in Nature Cancer that looked at all patients with ESR1. And what thought that this could actually potentially promote clinical resistance to a combination of alpelisib and aromatase inhibitor. So what the author showed was that at baseline, if you sequence the tumor of your patient, you would not see clinical benefit, if there was a PTEN mutation or an ESR1 mutation. Now, you can't always acquire the mutation at the baseline tissue. You may acquire them over time. So ctDNA actually helped pre and post to actually catch this. And the presence of an ESR1 and a PTEN mutation could actually indicate resistance to the combination of anti-estrogen and PI3 inhibitors. So my key take-home messages are that I think when we're talking about breast cancers, tumor profiling is important because it helps us understand the tumor biology, which in turn helps guide better treatment options. BRCA gene and the genes in the DNA damage repair pathway are extremely important. And if you are going to be using a PARP inhibitor, please beware of BRCA reversion. And liquid is also a good option, especially when tissue is initial. And on that note, thank you very much.
Thank you, Dr. Aparna, for excellent talk and actually making us aware of the ctDNA importance and in breast carcinoma especially. Thank you so much. Now, I would like to close the meeting. And I'd like to thank the organizers, Dr. Meenu Walia and Dr. Vikas Talrecha, course director, Dr. Anurag Mehta, for giving me this opportunity. The program this time included papers on cutting edge research, and all the faculty has put in immense amount of effort to prepare and present the content in easy to understand and in lucid manner. And I really am grateful to all the faculty, all the panelists, and all the moderators for doing excellent job. I think we have all benefited by this exercise and learned about new research, potential biomarkers and treatment modalities for breast cancer. And this is a very convenient way of going through so many abstract and with so many young people participating. It was an excellent, I think, learning experience. Now, as we have seen in all the abstract presentations, that the breast cancer now needs to be correctly classified into intrinsic subtypes by expression profiling, as IC classifiers may not differentiate the poor responders in the particular subtype. Now, we also explored the resistance mechanism of ER, HER2, and we saw the HER2 heterogeneity role of CRISPR as a diagnostic tool, and prognostic and predictive role of gene expression profiling in risk stratification. And maybe in future, the NGS panel will become an important part in guiding the patient treatment of breast cancer. The BRCA testing, the solutions to issue of PUS were deeply discussed, and maybe this clinical dilemma will be over, as Dr. Mashmi said, by 2030. Now, we also explored the role of computational pathology, which is a disruptive modality in pathology, in diagnostic, predicting genetic profile, and risk stratification on just H&E whole slide image, and which may permit us to go beyond morphological classification and prediction and give our oncologist a very good and robust information. I hope these 3 hours are well spent, and I request everyone to join the main conference tomorrow, which will include many more topics and debates. I again thank the San Antonio Breast team who has assembled this conference, and all the faculty, chairpersons, and audience again for fruitful academic evening. So I close this meeting. Good night, and all of you, please stay safe.
Okay, sir. Thank you so much, sir.
Yeah.